I think now it must be perfect. I feel so. I start a new session now. I think, is it okay now? I checked everything. Everything is fine. So I don't think hereafter there will be an issue. Okay. All right. Okay. So if it's fine, let us start with where we left yesterday. Yesterday, I think we have left with the localization of the stroke. I think everyone will be now familiar about how to localize a stroke in the first place. So we are going to today start with other important aspects of stroke, especially in the form of a pontine hemorrhage. And we have something called a locked-in syndrome, and it's duty to also learn about something called brain death. So even that is important. And we have a lot of variants of stroke. Don't try to confuse whatever the named strokes have given in medulla, midbrain, or in the pons. It applies only to the level of exams. But if you really take from the textbooks, standard textbooks, what are the different other types of strokes are there? You have multiple different types are there. Like medullary variants, only you have like 15, 20 types of strokes are there. And pontine variants, only like 10, 15 are there. Midbrain variants, another 5, 6 are there. So if you want to know, there will be keeping on, you'll be only knowing about the named strokes, and there will be no end for that. So I think whatever I told you must be enough, and that is more than enough for us. And now let us move on to the 3 other important things. So locked-in syndrome, second is pontine hemorrhage, and third is your brain death. So now to diagnose and what are the criteria for brain death, which is going to be very, very important for exams as well. So let us start with locked-in syndrome first. So what do you mean by locked-in syndrome, and what is called locked-in syndrome? What is the name? I mean, how can you understand this locked-in syndrome? Anyone? To start with, let us be a little interactive. Let us, I mean, after that, it's okay. I will take over. What is locked-in? Is there any special name for that? Not heard before. Okay. So that is nothing but a bilateral ventral pontine lesion. Yeah. That's otherwise referred to as a bilateral ventral pontine syndrome. I will tell that this has probably bilateral foveal. To start with, like you can imagine, like it could be a bilateral foveal syndrome. So when you take a foveal syndrome, what'll happen? So I mean, just for understanding, I'm not telling you need to write bilateral foveal syndrome. That's not the right way. But to begin with, we can understand it as a bilateral foveal. So what are the things that happen in a foveal syndrome? You're going to tell me. What are the things that are affected in foveal syndrome? Yes. So you have 7. First you have 6, plus you have MLF, that is medial longitudinal fasciculus, plus you have 7th cranial involvement, plus along with it you have hemiparesis. All right. So we have another new terminology here that is called as medial longitudinal fasciculus, which you have not learned yet. So we don't know what MLF does. MLF is basically a connection. We know that. But before that, let us see how the horizontal eye movements happen to begin with. So I'm not talking about the vertical eye movements. I'm only going to talk about the horizontal eye movements. Let us take the right eye and the left eye. Okay. You have the left eye and you have the right eye. You're seeing from the top. So this vision is going to be from the top, probably from the axial section you're seeing from the top of the eyes. So if you want to imagine, so this is going to be the 2 recti muscles, the lateral and the medial rectus. So you can imagine that this is a lateral rectus, this is a medial rectus for the left eye, and this is a medial rectus for the right eye, and the lateral rectus for the right eye. So now you know how these muscles are going to be separated. Yeah, Ishan didn't understand that. Okay, fine. Let us come back to that in some time. So now how this movement happens in the first place. Let us put a midline here. This is supposed to be the midline section. And the movements typically start from the frontal eye field only. So let us start with the frontal eye field first. frontal eye field. This frontal eye field gives information to the superior colliculi. You know where the superior colliculi are? Superior colliculi is going to be in the brainstem, in the midbrain. So, and this superior colliculi is going to give information to the opposite side to an area referred to as something called a PPRF. That's a prepontine or a parapontine reticular formation. Both are same only. So once the information comes to the PPRF, this information goes to another zone. This is called as cranial nerve 6 nucleus. That's a CN6 nucleus. You know, the whole idea is like you can understand now, if it comes to the cranial nerve 6 nucleus, of course, this cranial nerve 6 nucleus is going to give rise to something called an abducens nerve. This is the cranial number 6. And through this process, it means as if you end up with movement of only left lateral rectus, which means only one eye, left lateral rectus alone is moving to the left side. But in the eye, there is something called conjugate eye movements. So whenever you move the eyes, you can move both the eyes to the same direction. Whenever you move the eyes to the left, which means both the eyes should move to the left. And whenever you want to see on the right, both the eyes will move towards the right. That's how our body is oriented. Yes, that's not only sockets, a lot of other kinds of movements are also there, smooth pursuit movements. So that is not the need of the discussion right now, but how the eyes are able to produce that kind of conjugate eye movements, which means to produce a conjugate eye movement, the left eye should move to the left. At the same time, the right eye also should move to the left. Then only you can produce a conjugate eye movement. Otherwise, you will result in disconjugate eye movements. So to produce that right eye to move to the left in this particular scenario, you need to stimulate this medial rectus also. But you know, the stimulation of the medial rectus is going to come from the oculomotor nerve nucleus. It's not going to be coming from the sixth nerve nucleus. You need something called the oculomotor nerve nucleus for that. Let us assume this is a cranial number 3 nucleus on the other side. And the cranial nerve number 3, you know, the famous mnemonic is there, no? LR6, SO4, then remaining everything is 3. So which means apart from the lateral rectus and the superior oblique, every other muscle is supplied by the cranial nerve number 3 only, including the medial rectus, including the superior rectus, inferior rectus, and inferior oblique. And of course, I have not drawn the levator palpebrae superioris here. If you want to draw, I can draw separately. That's a central nucleus will be there. That is levator palpebrae superioris. Remember, oculomotor nerve nucleus has many subnucleus within them. And let us assume in a simple way, and these are the subnucleus. There are many subnucleus. This is only a conceptual orientation. So these are few subnucleuses that are seen within the cranial number 3 nucleus. And there should be something that should be able to stimulate that medial rectus to get stimulated so that you can produce a conjugate eye movement. So that function is what is done by a medial longitudinal fasciculus, which means there will be a bundle of fibers which will be traveling from the 6th nerve nucleus towards the medial rectus of the other side, the oculomotor nerve nucleus. So this connecting fibers is what we refer to as medial longitudinal fasciculus. So this is what we basically refer to as something called a medial longitudinal fasciculus. And this is a bundle that connects the 6th nerve nucleus on one side to the medial rectus on the other side. So which side you should name the medial rectus? So I think I can draw in a different way because the direction here that is drawn is not correct. So which side you will name the medial rectus is side that is going to innervate the medial rectus. So that is the side we need to name the medial rectus as. For example, I can draw something like this, but the concept is going to be the same. It's not going to differ. So I can draw like this. So whatever side the medial rectus is supplied, so that is the side you can imagine that is the side of the medial longitudinal fasciculus. So this is the MLF basically. That is the connection between the 6th nerve nucleus and the 3rd nerve nucleus on the other side. So this MLF is a very important bundle because this is the one that makes the conjugate eye movements possible, which means through this pathway, whenever you want to look on the opposite side, which means the frontal eye field is stimulating the superior colliculus, then it stimulates the other side PPRF to stimulate the abducens nucleus. The MLF will also be stimulated so that your medial rectus also is going to get stimulated and is going to contract and your eyeball moves towards the left side. So that's hence proved, like we know that right frontal eye field is important for movement of the eyeballs towards the left side. So that's all. Similarly, left frontal eye field is going to move your eyeballs towards the right side. So all these are expected only. So which means medial longitudinal fasciculus is basically a connecting bundle between the abducens nucleus and the oculomotor nucleus. It's not only for the third and sixth nerve, I mean, not only for the horizontal gaze, it's also there for a vertical gaze also. Even this MLF bundle is important for vertical gaze as well, when you want to move both the eyeballs simultaneously towards the upper direction. Is that the third nerve nucleus on the right? Yes, we have. I mean, if you want to zoom and see, I can show you. This is a third nerve nucleus only. This is the cranial number 3 nucleus only. I think that must be it. So this is the function of the MLF. So whenever MLF is damaged, so it is given a special name. So remember, whenever your muscle is damaged, you can get ophthalmoplegia, all right. So whenever neuromuscular junction is damaged, like in myasthenia gravis, you can get ophthalmoplegia. Whenever the cranial nerves are damaged, still you can get, yes, ophthalmoplegia, no doubt about that. But whenever your MLF is damaged, that has got a special name that is called internuclear ophthalmoplegia, INO. So MLF damages usually result in something called INO, a very peculiar phenomenon. So why it results in internuclear ophthalmoplegia? Because you get an ophthalmoplegia that is not due to a nuclear lesion or not due to a nerve lesion. It's due to a fascicular lesion, that is MLF lesion, that is running in between the two nucleus. So because it's due to a damage to the fibers that are running between the two nucleus, it is referred to as something called a internuclear ophthalmoplegia. It's not in the nucleus or not after the nucleus, it's between the two nucleus. So it's an internuclear ophthalmoplegia, MLF damage. The characteristic feature of internuclear ophthalmoplegia will be your inability to move medial rectus on that particular side where the MLF is damaged, because if the right MLF is damaged, then this right side medial rectus will be difficult to mobilize. So that's what will happen. But you might be arguing that if right side medial rectus is not moving, that can be due to either a muscle lesion or it can be due to oculomotor nerve lesion. Oculomotor nerve lesion, or it can be due to oculomotor nerve nuclear lesion also. How can I clearly tell that it's a MLF lesion, to be precise? So if the right side medial rectus is not moving in this particular example. So that's the most important point, because as far as the internuclear ophthalmoplegia is concerned, the accommodation reflex will be preserved, because both have a completely different pathway, accommodation reflex and conjugate eye movement pathway. So for example, what happens in accommodation reflex? Accommodation reflex, it's a completely different pathway. It doesn't follow the MLF pathway, and they are going to use a different set of fibers in accommodation. Let us take what happens in accommodation. Everyone knows what happens in accommodation basically. So there are 3 C's that happened in accommodation. Anyone can summarize or anyone can type and show me what are the 3 C's of accommodation? Yes, number 1. So it's a convergence of eyeball. Okay, all right. Then constriction of pupils and change in the anterior curvature of the lens. Yes, change in anterior curvature of the lens, constriction of the pupil, and convergence of eyeballs. So if you tell convergence of eyeballs, that's a conjugate eye movement or disconjugate eye movement? Conjugate or disconjugate? That's not a conjugate eye movement, because the right eye, the left eye is moving towards the right and the right eye is basically moving towards the left. So it's not a conjugate eye movement, it's basically a disconjugate eye movement. When I tell divergence, it's a conjugate eye movement or a disconjugate eye movement? Of course, it's a disconjugate eye movement. So whenever I tell convergence or divergence, so of course it's going to be a disconjugate eye movement. It's not a conjugate eye movement. So that is the reason why these have a completely different pathway. They are not same pathway, they are completely different pathway. So if you ask where the pathway starts from, you have the occipital cortex. In the occipital cortex, you have certain areas called as peristriate areas, area 17, I guess. But Brodmann's areas are very useless for exams. Don't remember them. You have occipital cortex, we have a peristriate area, usually from the dominant occipital cortex. That is where the location is. So from the peristriate area of the occipital cortex, you're going to result in stimulation of midbrain, basically. In the midbrain, in the dorsal area, in the posterior dorsal region, there is a region for accommodation. There is one region for accommodation region is there. Dorsal area of the midbrain. From that particular zone, you will be stimulating two different areas within the midbrain itself. One is stimulated because in the midbrain you have two things. One is the oculomotor nucleus and second is the Edinger-Westphal nucleus. It's a very simple pathway. So why I want to show is for a different reason, not for like what you think. So you have an Edinger-Westphal nucleus, which I can show in red like this. And you have an oculomotor nucleus also. I think I have to show a bigger kind of a box. Okay, let me put a bigger box. So let us assume this is a midbrain. So this is the Edinger-Westphal nucleus. And we have the oculomotor nucleus as well, which has that four characteristic categories, subnucleus. Oculomotor nucleus. So from this accommodative zone, the fibers are going to come that are going to stimulate both the Edinger-Westphal nucleus. At the same time, they are going to stimulate the fibers of medial rectus subnucleus of oculomotor nucleus as well. So now through this simplified pathway, what is happening is first through the Edinger-Westphal nucleus, you are going to have parasympathetic stimulation, number one. At the same time, through this medial rectus subnucleus, you are going to stimulate the bilateral medial rectus as well, both side medial rectus as well. So ideally speaking, if you take this pathway, it has nothing to do with the your MLF pathway, conjugate eye movement. It's a completely different pathway because both sides parasympathetic pathways are stimulated. You will result in constriction of pupil. At the same time, because both side medial rectus are stimulated, you are going to result in convergence of the eyeballs, which means there is nothing to do with your MLF. So in no way your MLF is involved. Suppose if MLF is damaged, it should not be having any impact on the medial rectus movement as far as the convergence pathway is concerned. So that is the accommodation reflex. So that is the reason why in INO, one of the important differences is accommodation reflex will still be preserved because it follows a completely different pathway. Because accommodation is a disconjugate eye movement that is coming from a completely different pathway, and INO is a completely different entity. So both are completely dissociated. So you're asking what is the yellow part? I mean, this is an accommodative area in the midbrain. Accommodation area in the midbrain that is present in that's a vague gray matter that is present in the dorsal area of the midbrain. That is important for accommodation. From the midbrain only your things go, and there is no specific name for that particular area. Even though some textbooks attempts to give that, we don't have any specific name. From that area only you are going to get the stimulus for the accommodative reflex. The idea is very simple. Rather than knowing the exact area, it's important to know that both are completely dissociated and conjugate eye movements are not going to follow the similar path to that of accommodation. And if you watch carefully, for accommodation reflex, you need your CNS involvement. CNS is important for accommodation, which means your brain is important for accommodation. Clear? At the same time, to get this conjugate eye movements, again your brain is very important, which means the cortex is very important for accommodation. And again, cortex is very important for the MLF pathway, that is conjugate eye movements as well. But there is another reflex where cortex is not important at all. What is that pathway? Everyone knows that. Which pathway you don't need the cortex? The occipital cortex is no longer required in that pathway. Yes, light reflex pathway. That's a pupillar reflex. So you don't really need the cortex in that setting. So all you need is the midbrain only. Everything happens through the subcortical centers. So you don't need the cortex. No cortex required here for pupillar reflex. You know what happens in the setting of a pupillar reflex? So let us assume This is the fibers that are coming from the eyes that are crossing up. And we know there are certain fibers that don't cross up as well, like this. And approximately 5 to 10% of the fibers that are passing through the optic tract into the thalamus, because after some time they're going to end up in the thalamus, the lateral geniculate body. But before that, we know there are some fibers which are going to enter the midbrain. Approximately 5 to 10% of the fibers enter the midbrain, and they're going to stimulate an area called pretectal nucleus. We have something called a pretectal nucleus, and this pretectal nucleus are going to further stimulate the Edinger-Westphal nucleus. So let us assume this is a Edinger-Westphal nucleus here. And there is no stimulation to the oculomotor nucleus though. So the stimulation will be only to the Edinger-Westphal nucleus. So from the Edinger-Westphal nucleus, your parasympathetic fibers alone will be stimulated. That alone will be stimulated so that you will result in constriction of pupils. So this is a pupillary reflex pathway. And at the same time, we know that Edinger-Westphal nucleus is connected strongly with each other. So the response will be usually bilateral, and that is the reason for consensual right reflex. And the pretectal nucleus is also strongly connected with each other. And that is also one reason why you get a consensual light reflex. That's a bilateral response. And similarly, because if you take, the fibers are basically crossing at the optic chiasma, and that is also one reason why whenever even one light is stimulated powerfully, because one group of fibers are going and the other side another group of fibers are going. So again, that is also one reason why you get a consensual light reflex. So get a consensual light reflex, you have so many reasons. First, it starts from the crossing at the chiasmal level, which means always the stimulus, even if it's given in one eye, it's going to go to the other side also. And there are also strong connections between the Edinger-Westphal nucleus and pretectal nucleus itself. So that is the reason for consensual light reflex. Anyways, fine. So if you see, this is the light reflex. And of course, here there is no cortex required at all. So which means for a light reflex to happen, you don't need cortical areas, which means light reflex is basically a subcortical reflex. All you need is this pathway to be intact, which means you need only midbrain and the related pathways. And the optic nerve and the midbrain should be intact to produce a light reflex. That is more than enough to produce light reflex. There is no problem at all. So this is also telling you that light reflex also doesn't need any MLF. Light reflex doesn't even need this accommodation pathway also. Accommodation is happening through a different pathway. Light reflex is happening through a different pathway. Conjugate eye movements is happening through a different pathway, which means all these pathways are basically dissociated. So that is why you encounter a famous word in ophthalmology, or when you take a neuro-ophthalmology or any medicine textbook, they'll give something called a light near dissociation. So basically the pathways are dissociated. That is true. And sometimes, usually, whenever there is a light reflex, there will be accommodation reflex also. Clinically, light near dissociation means whenever there is a light reflex, but there is no accommodation reflex. But whenever there is an accommodation reflex, but there is no light reflex, this is where we call it as a light near dissociation. But from a physiological point of view, if you see, both these pathways itself, from a basic physiological point of view, are dissociated only, in the sense like both are not the same. Both are happening through completely different pathways. And that is the reason why they can be dissociated in pathologies. For example, if you take a simple disorder like neurosyphilis, which you have been studying all your life, if you damage the pretectal nucleus, bilaterally, you will not be able to get the light reflex. But because damage to the pretectal nucleus doesn't have any impact on accommodation, the accommodation reflex will still be present. That is what we refer to as a Urgell-Robertson pupil, where there is a light near dissociation clinically. So that's all right. That's understandable again. So similarly, whenever there is an internuclear ophthalmoplegia, there is no way you are going to involve the light reflex or the accommodation reflex, which means accommodation reflex and light reflex will still be present. In a sense, I need accommodation reflex to be checked in any patient with internuclear ophthalmoplegia, because I need to confirm that this patient who's not having a movable medial rectus in the conjugate eye movement, whenever I voluntarily move the eye, but they are able to move this medial rectus when it comes to accommodation reflex, which means during the accommodation reflex, both the medial rectus will move properly in the setting of an INO, because it's a completely different pathway. But a patient who's having an internuclear ophthalmoplegia, I mean, in the setting of internuclear ophthalmoplegia, even though accommodation reflex is there, but the patient will not be able to move the medial rectus when they are asked to do voluntarily, because that's not possible, because MLF is important in that setting. Do you understand this? All three pathways. So what is MLF pathway? What do you mean by light reflex pathway? And what do you mean by accommodation reflex pathway? Basically, all these are completely different and not going to be the same. So that is the basic take-home point at the end. So lesions of one pathway may or may not affect the lesions, the other pathways. So that is the final take-home point. Okay. Now you know what is MLF. Right now, if you want to know what is MLF, for time being, we can understand MLF stands for medial rectus. That's all. That's all. For time being, we can tell MLF means medial rectus. Nothing much. Clear. That's all. That's what we're going to understand, especially during the voluntary gaze, not during the accommodation or pupillary pathway. MLF is important for voluntary gaze, conjugate gaze, and it is going to supply the medial rectus on the same side, ipsilateral side. Okay. So suppose if you put everything bilateral, since I told you, imagine like a bilateral Foville syndrome in locked in state. So put bilateral. So you're going to get a bilateral sixth. You're going to get a bilateral MLF. You're going to get a bilateral seventh. And you're going to also get something called a bilateral hemiparesis. Just this is for understanding, just to make it like a spoon feeding kind of a scenario. So when you have a bilateral six, both side lateral rectus is gone. When you know bilateral MLF is lost, bilateral medial rectus will be lost. Clear? Which means MLF means right now we know it's medial rectus on the same side. So bilaterally both side MLF is gone. So both medial rectus is also gone. So this will definitely result in complete loss of horizontal gaze. Complete loss of horizontal gaze. Correct? Yes. And when bilateral seventh nerve is involved, so both sides, there will be complete loss of facial expression. So the patient will appear as if he's dead. So dead face, emotionless. He cannot express anything. No form of expressions, because both sides, it's an element. Remember, whenever you talk about a brainstem stroke, it's not UMN. It is basically a element, seventh nerve palsy. So definitely it is a complete loss. Upper, lower, everything will be lost. And more importantly, we didn't discuss this very important thing in the previous zone when we have been discussing about the UMN seventh nerve versus LMN seventh nerve. Remember, in UMN seventh nerve, basically, we are talking about a ipsilateral lesion or a unilateral lesion. Emotions will basically preserve in a UMN lesion. But whereas in LMN lesion, emotions will be lost. So this is also one important difference, especially on that particular side. So emotions will be completely preserved in a UMN lesion, but on a unilateral LMN lesion, on that particular side, emotions cannot be given as well. Emotions will be lost. So why is that so? Why emotions can be preserved in a UMN lesion? Once again, it's very simple. You go back to that initial diagram where we saw. I think you'll be familiar with this diagram because we discussed about this yesterday itself, where there are something called sham fibers that are coming from the frontal lobe. These are nothing but frontopontine fibers passing through the anterior limb of the internal capsule. We discussed yesterday already. So these fibers are the ones that modulate the seventh nerve at the pontine level, functions of the facial nerve at the pontine level. So even if there is damage to the UMN fibers, if there is some damage to the UMN fibers, especially those of the corticospinal tract or the corticobulbar tract to be precise, now this still, if this prefrontal cortex fibers, that is the sham fibers, frontopontine fibers in the anterior limb are still intact, then you might be resulting in modulation of your emotions at the facial nerve level, so that emotions can still be possible despite the fact that the motor fibers are severed. So that is the one of the reasons why, despite having a UMN seventh nerve palsy, you can still preserve emotions. So in LMN, it's not possible because it's below everything. So in the nucleus or below the nucleus means it's a terminal end. So anyway, no fibers can act in that scenario. So that is the reason why these patients will not have emotions and they cannot show any expressions. And if bilateral hemiparesis means, just for understanding, I'm telling, it can be translated into something called a quadriparesis. So patient will be quadriparetic and he'll be in the wheelchair. And everyone knows, a common category, everyone would have studied, everyone would have seen that Munnabai MBBS movie where there is a character called Anand Sir is there. So that is a typical locked in state. So typically everything they would have explained much better in that particular movie. They would have told that that particular guy is in the wheelchair in a quadriplegic state. He will be completely emotionless. He cannot show any kind of emotions. And he will be having eyes and still like this. He cannot move any side, right, left. He will not have any kind of movement. So complete loss of horizontal gaze. So this is a sort of a locked in state, which means it looks as if the patient is dead, but he is alive. So it's a kind of a very tough scenario for the patient. But what are the other things that can be basically preserved in these guys? So what are things that are preserved? Even though so many things are lost, patient cannot show any sort of expressions. What are things that are preserved? The first thing that is preserved is consciousness. That is very important because consciousness is basically coming from the deeper portions of the brainstem. That is not damaged. This is a superficial syndrome, bilateral ventral pontine syndrome. For that matter, you can remember like a bilateral foveal syndrome for that matters. So, but anyways, nevertheless, the deeper portions of the brainstem like reticular formation, which is the seat of consciousness, is basically preserved. So consciousness will be preserved. So the patient is well conscious in this. And second thing that is preserved is a vertical gaze. Vertical gaze will be preserved here. So which means patient can move eyes up and down to some extent. Not completely, but to some extent they can, depending on the damage, they can move the vertical, eyeballs vertically up and down to a great extent. So that is one thing. Number 3, all the 4 structures are preserved, which means it's a medial syndrome basically. It's not lateral syndrome, which means the lateral structures, the side structures, the 4 structures are basically preserved here. The most important of that being the spinothalamic tract and spinal nucleus of the trigeminal nerve. So if both these things are preserved, which means the pain and temperature sensation will be preserved, which means the sufferings of the patient will be true, real, which means if somebody pinches, they cannot express that somebody is pinching. They'll be still seeing like this, but they'll be suffering from the pain. The pain will still be there and they can suffer. And they know that somebody is causing hurt to them because they are conscious also. And at the same time, the sympathetic system is preserved. If the sympathetic systems are preserved means they can feel the temperature, the body temperature will be normal, the thermoregulation will be normal. At the same time, more importantly, that will translate into a clinical finding called pupils will be normal, normally reacting in these fellows. And there will be intact light reflex also because sympathetic system and the parasympathetic system, all these things are basically intact. And it's basically a pontine syndrome only. And everything above the pons is also preserved. So let us see what all things will happen. And this is also shown actually in the movie that I think there will be one scene in that movie where they will do light reflex till the pupils will contract. I think that is shown in the movie if you remember carefully. So they have shown a lot of correct things, but I'll tell you what is the stupidity there. But of course, our Indian movies come with some stupidity that should be there at the end. But nevertheless, so why your pupillar reflex is still preserved? Let us assume. So you have the midbrain, you have the pons, and you have the medulla. You have 3 different group of structures are there. And this is a syndrome in the pons. For example, let us assume the medial part of the pons is completely destroyed. Ventral medial pontine syndrome. So medial part of the pons is destroyed. Yeah. So now what's going to happen is, you know that parasympathetic fibers to the eyeballs. This is from the Edinger-Westphal nucleus. Parasympathetic fibers to the eyeballs are basically coming from the Edinger-Westphal nucleus from the midbrain level. So that's fine. So that will be completely all right. And at the same time, I told you the side structures. For example, your sympathetic fibers. These are the side structures, the spinothalamic tract, pain, temperature. These are all intact, no problem. Which means the sympathetics basically come from the superior cervical ganglion to the eyes. We have studied that also, where it goes winding along with the internal carotid artery. We know that. And sympathetic to the eyes is also preserved. So these are basically sympathetic. So basically the sympathetic system and the parasympathetic system both are intact. So that is the reason why pupils must be normally reacting to light. So there should not be any change. Okay, point number 1, noted. But one important thing is like your vertical eye movements will be intact. So why vertical eye movements should be intact? Because they are starting from the midbrain, not from the pons. Please take my word that pons is a center for horizontal gaze. but midbrain is a center for vertical gaze. So this is something really important to understand. That's why especially the dorsal portions of the midbrain will be the center for vertical gaze, and the ventral portions of the pons will be the center for horizontal gaze. This is a very important and relevant point to neuroanatomy. If you go and study every neuroanatomy textbook, and if you see the pathways, finally you'll be coming to that conclusion only, that the ventral portions of the pons will be the center for horizontal gaze, and the dorsal portions of the midbrain will be the center for vertical gaze, moving up and down. So here, since the pons is damaged, the ventral part of the pons is damaged, the horizontal gaze will be lost. But at the same time, because, okay, let it be. So because your midbrain is still intact, it's preserved. So the vertical gaze, the dorsal portion of the midbrain is still intact. The vertical gaze will still be preserved. There will be no problem in the vertical gaze. All right, we know that as well. At the same time, the medial fibers, these are the corticospinal tract fibers. These medial fibers, especially the corticospinal tract fibers, MLF fibers, are basically damaged in locked-in syndrome. So whatever these fibers that are coming down, this corticobulbar fibers, corticospinal fibers, are basically broken at the pontine level itself. So definitely they cannot come down at all. So the corticospinal tracts are damaged, and the corticobulbar tracts are also damaged. These corticobulbar tracts are the ones that are going to supply the nucleus of the medulla, medullary nucleus. Clear? So because Riju is telling, can you tell a little about vertical gaze pathway? It is not well explained of the, I mean, for that matters, do they explain the horizontal gaze pathway well in ophthalmology? Riju? I mean, I'm not telling it's wrong, but during my time, even horizontal gaze pathway will not be well explained in ophthalmology, basically. I mean, as far as I know. Anyways, fine. So you have this kind of disruption of the corticospinal tract pathways at the level of the pons itself. At the level of the pons itself, your corticospinal tract will be completely disrupted. Because it is completely disrupted at the pontine level itself, this corticospinal tract fibers will be lost at the same time. At the same time, this bulbar cranial nerves also will go for bilateral paralysis, because this corticobulbar tract fibers cannot now reach the medullary cranial nerves because they are disrupted at the pontine level itself. So most importantly, you will end up in a scenario called as bulbar palsy. I mean, in the sense, we'll call it as pseudobulbar palsy. I'll tell you why. So you'll end up in a scenario called as pseudobulbar palsy. That's very important, because bilaterally, the Uoman bulbar cranial nerves are damaged. So that is the reason why you are ending up with a pseudobulbar palsy. Okay, fine. This is a very important point. But the midbrain cranial nerves are basically intact, which means this corticobulbar fibers that are supplying the midbrain cranial nerves, they are intact. So the third and fourth cranial nerves will be normal. So third and fourth will be normal. No, you are thinking like only, see, Nindra is asking only 12th cranial nerve should be damaged. Why others are lateral? No. Other cranial nerves are basically emerging from the lateral side. All right, I'm not telling. No, your, ninth cranial nerve, 10th cranial nerve, and 11th cranial nerve, yes, they do emerge from the lateral side only. But first of all, where they emerge from? If you ask that question, they are basically emerging from the nucleus. They're basically emerging from the nucleus, their respective nucleus. For example, it could be 9th nerve, 10th nerve, or 11th nerve nucleus. And who is supplying this nucleus? I mean, who is the supply for this nucleus? Which means the nucleus cannot be like Swayambhu, right? They should be supplied by something. Who is supplying this nucleus? Answer the question, Indra. Yeah, Uoman. So Uoman fibers. So you know there are Uoman fibers. Where these Uoman fibers are coming from? These are corticobulbar tract. So where these Uoman fibers are coming from? You think they are coming on the lateral side, Uoman fibers? Indra should answer the question. They are coming from lateral side or medial side, these Uoman fibers? Lateral or medial? Where these human fibers are coming? From the medial side. If they are damaged in the pons itself, how can they supply this nucleus? In the medulla. It's not possible. So, I mean, because they are basically disturbed at the pontine level itself. They are damaged at the pontine level itself and it's bilateral also. So, they end up in a scenario called as pseudobulbar palsy. That's all. So, this is basically a locked in state. Now, let us see what they have not explained. And of course, one of the biggest blunders in the movie is like at the end, the patient will get up, come and hug the hero, and because like that's not possible really, because locked-in syndrome is basically a very poor prognostic state. The patient will invariably die within a few months because it's not possible to sustain for that long, because it's a very severe disease basically. And second, in medial pontine syndromes, corticobulbar is also damaged. Yes, I mean, I didn't tell corticobulbar or corticospinal. We have just talked about motor pathway. For example, I told you corticospinal tract. So any motor pathway, including corticobulbar and corticospinal, is going to travel through the medial areas only. So motor means medial, that's all, whatever may be the case. The corticobulbar is basically coming from the medial side only. Okay. So fine. So what is, of course, the things that are not shown in the movie. So one thing that is not shown in the movie is the pseudobulbar palsy that this patient experiences. So these patients will be having pseudobulbar palsy, which means they should be basically in a Ryle's tube only. They should not be without a Ryle's tube, isn't it? They should have basically been in the Ryle's tube, but this patient is not in the Ryle's tube. That is because it's not shown. That's all. Maybe they have paid less to the actor. That's all. So pseudobulbar palsy is something that is not shown. And the patient should have vertical gaze, that is not shown. But all the other things are depicted very nice in the movie. Fine. So you can imagine that as a locked in state. And this is not brain death. This is not coma. This is something in between. It's not a brain death state also. It's not coma also. I mean, which language you are Hindi or Telugu or Kannada or Tamil? Hari is asking what movie. Depending on that, I will say, because that movie was remade in almost every language. He's Tamil. Then they see Vasul Raja MBBS, man. then why you are seeing Munna by MBBS? Corticobulbar fibers travel along with the corticonuclear fibers anterior to tegmentum. Yes, that's how they travel. Okay. All right. So now you understood what is locked in state. This is our locked in state. This is not a comatose state. This is, of course, not a brain dead state as well. This is somewhere in between where the consciousness is preserved. Patient will be quadriparetic, pseudobulbar palsy. And at the same time, patient will not have any kind of expressions, but the pupils will be reactive and the patients can hear, patients can see, patients can have vertical gaze, and patients can feel the suffering. Pain and temperature is also intact. So these are the most important things that you have to know as far as the locked in state is concerned. One of the important causes of locked in state, is iatrogenic. That is faster correction of hyponatremia. That will result in something called a osmotic demyelination syndrome, previously called as central pontine myelinolysis. Currently, it is called as osmotic demyelination syndrome, one of the important causes of locked in state. We have seen some 2-3 patients with faster corrections of sodium resulting in locked in state. That is because of that myelinolysis. Basically, 9, 10, 11, 12 have Eumann palsy. This is what I understood. Yes, basically 9, 10, 11, 12 will have bilateral Eumann palsy, not unilateral Eumann palsy. Basically, unilateral Eumann palsy should not affect the cranial nerves that much, except the lower part of the face. We have discussed yesterday itself. Except for the lower part of the face, unilateral Eumann should not affect the other cranial nerves that much. But since this is a bilateral Eumann palsy, nevertheless, they will be damaged, surely. So they will be having serious consequences. So then next thing is to know about the pontine hemorrhage. What happens in pontine hemorrhage? Here you can imagine like a complete destruction of the pons. Remember, pontine hemorrhage has multiple variants. Multiple variants in the sense like you're going to have like hemiparesis, quadriparesis. Depending on where the bleeding is, you can get significant impact. But on the other hand, typical textbook description of Pontine hemorrhage will be like this. Like this will be kind of a complete destruction of the pons. The patient has complete destruction of the pons due to hemorrhage. Number one, patients will be unconscious. That's the most important thing. And they will be in deep coma. Deep coma. So which means patient cannot be arousable at all because the reticular formation is also damaged here because it's the seat of consciousness. If that is broken, you cannot get up. Patient will be in deep coma. And second, of course, if the pons is damaged, the horizontal gaze will be completely lost. I mean, you should not tell gaze because if the patient is in coma, the word gaze is wrong because only voluntary eye movement should be called as a gaze. Whenever the patient has eye movements in the presence of coma, that should be called as only eye movements. That's not a gaze. So the patient may have vertical eye movements still, even in a comatose state. Vertical eye movements can be persisting. That is due to like imbalance between the vertical and horizontal eye movements. So vertical eye movements can be there, but it will not be coordinated because it's not voluntary, it's not controlled. So it will be uncoordinated vertical eye movements. And that's what we refer to as something called ocular bobbing. So if they ask you where you get ocular bobbing, typically you will get this kind of ocular bobbing in Pontine lesions. So that is uncoordinated haphazard vertical eye movements that happen in the setting of a Pontine lesion. Not only Pontine hemorrhage, any Pontine lesion can cause that. Apart from that, what else is spared? Like a parasympathetic will be spared, but because the entire pons is destroyed, even the 4S structures, that also will be lost. So the sympathetics will be lost, only the parasympathetics will be there. So because of overactivity of parasympathetics, you are going to result in pinpoint pupils. And the biggest question is whether these pupils will be reactive or not. Of course, these pupils will be still reactive to light in the sense like, but you cannot really appreciate it. If you see in the slit lamp, you can appreciate, even though the pupils are very small, still they will be reactive to light. There's no reason why this should not be reactive because if the optic nerve, eyes, and the pretectal pathway in the midbrain is intact, means definitely pupils will still react to light. So there's no reason why pupils should not react to light, but just because they are very small, you're not able to appreciate it. So still they will be reactive to light. That's also one of the questions in the past. And next, the patient will be in quadriparesis, of course, because the entire motor pathway is destroyed. The patient cannot feel any pain and suffering here because the patient is in coma. Once you tell the word coma, no sensation in the face or in the body. So the patient cannot feel any suffering. How much ever pain, temperature you give, the patient cannot feel it because the patient is already in a deep coma because reticular formation is destroyed. At the same time, your spinothalamic tract that is ascending and the spinal nucleus of the trigeminal nerve that is ascending to the cortex, both are damaged completely. So the patient will not feel anything. And at the same time, because sympathetics are damaged, you will result in poor thermoregulation, resulting in severe hyperthermia. The thermoregulation will be lost. In locked-in syndrome, because sympathetics are intact, thermoregulation was intact. But here, because the sympathetic system is gone, they cannot produce sweat and the thermoregulation ability will be lost and the patient will go for severe hyperthermia. Like the temperature may be around 103, 104 degree Fahrenheit all the time. So fine. So these are the typical features of a Pontine hemorrhage, which you would be able to know. And once we have finished off the Pontine hemorrhage, now next to final thing is the bigger topic, that is the brain death. And there have been a few number of questions on brain death in the recent topics. And declaring a brain death is not a very easy scenario. It's going to be extremely tough. And the idea behind brain death is to declare a brain stem death and not a brain death. That's the most important. It's actually telling about the brain stem death. And we're not talking about a brain death here. So you have to prove that the brain stem is dead. Remember, the spinal cord may be there or may not be there. We are not worried about that. It's all about talking about the brain stem. That's what we call it as a brain death, basically. If you want to tell in a simple terms, it's a constellation of three problems. One is the coma. That's the first thing. So which means the patient will be in deep coma. The GCS will be 3 out of 15, which means it's the minimum GCS that you can attain. That also translates that the patient will have absolutely no motor response to any sort of stimulus. Whether you take the hammer and hit on their head, they're not going to respond. So absolutely no motor response. But still there are some exceptions like Lazarus sign is there. That is an exception. But nevertheless, the patient will not get any motor response to any kind of stimulus. That's deep coma. That's understandable because reticular formation should be completely damaged to declare it's a brainstem death. and the patient should have absent brainstem reflexes. So none of the brainstem reflexes should be intact, completely absent brainstem reflexes, and the patient should be apneic, which means without ventilatory support, patient should not be able to breathe spontaneously. Because the patient is able to breathe spontaneously means the medulla is still intact, and that excludes a brainstem death or probably a brain death also. So the patient should be completely apneic. So we do something called an apneic test. So to do testing, first of all, you need to declare that the patient is brainstem death, which means you have to really tell that the patient is having no reflexes that are suggestive of activity of the brainstem. So you have to examine the patient. To examine the patient, you need some preconditions. There are some preconditions are there to examine the patient before declaration of brain death. So first precondition, this is a very important thing that will be asked in many institute exams. So first thing is cause, and a cause should be there that should be explaining that the patient should have a brain death. For example, a severe hypoxia, subarachnoid hemorrhage, or a cardiac arrest. There should be some precipitating cause that should explain that the patient is having a brain death. I mean, that should be compatible with the ability to cause brain death. Number one, that's the first thing. Second, you should start testing only after 4 hours of observation. At least you should give a cap of 4 hours. You should not start immediately. So in that 4 hours observation period, you will be doing some things which I'll be telling what all the things you will be doing. So at least 4 hours of observation is mandatory. You should not jump into conclusion, because these are potential organ donors, and because organ trafficking is a very illegal business, and many times this could bring a lot of legal implications on a doctor. So that's why you have to be very, very careful, and everything should be videographed. It's like whenever I am one of the doctors who declare brain death in Chennai. So whenever I want to declare brain death, I will videograph everything from the time I enter the room, not with the CCTV, with a proper video camera. I'm talking about in a DSLR. I'll take one person along with me, and from the time I enter into the room, from the time I am doing all the brainstem reflexes and all this stuff, I'll videograph everything, including the thing which I'm talking to the patient's attenders and to the other doctors. Everything will be videographed, so that is a very important future evidence for us, so that we will not end up in any soup later on. Because say later on somebody can come and tell, like, my son or daughter is not dead at all. This doctor falsely told he's brain dead, and they have cheated the organs. So that's a very bad reputation for you. So always videograph it. That's what I do. And anyways, fine. 4 hours of observation is important. And most importantly, the patient should have a normal temperature. Why this point has come is because after a cardiac arrest, we follow something called a therapeutic hypothermia. And it's very important that during the hypothermia, naturally, the brain activity will be suppressed. And during that time, if you examine, it's not possible to get a good reflex, and it might falsely be negative. So that is the reason why the patient should be having a normal temperature. By definition, it should be at least more than 35 degrees Celsius to be compatible with the testing strategy. Number 4, the patient should be having stable vitals. The patient should not have unstable vitals, so which means at least the systolic blood pressure should be more than 90 and the mean arterial pressure should be more than 60. Maybe with support or without support. Then the whole point will be lost. If you are doing examination, the patient is unstable, then anyway the organs cannot be procured because he's going to die and the organs are going to go for ischemia. So the idea of declaring a brain death is to procure the organs. And the patient should not be in any sort of sedation or paralysis. No sedation, no paralysis. Of course, that's understandable. To declare a brain death, the patient should not be in sedation or paralysis. Patient should have literally near normal electrolytes, even though mild fluctuations are understandable, like 146 of sodium or 133 of sodium is fine. But severe electrolyte disturbances are unacceptable. The patient should have basically normal or at least a near normal electrolyte values in the blood. And apart from that, patient should have at least one eye or 1 ear. At least one eye, 1 ear is mandatory. Many times we see a lot of road traffic accidents where the face is completely disfigured, where I have seen both the eyes have popped out and patient without eyes, without the ears will be deformed completely because there will be a truck that can move over the head. And these kind of scenarios, it's very difficult to declare a brain death, even though this is only a relative precondition. It's not an absolute precondition, but still that's really important. I don't really declare if the patient doesn't have eyes or ears, because I will not be able to do the testing, like for example, corneal reflex, congenital reflex, pupillar reflex, then the stimulation of the ears with water is there, no, cold water and warm water to see the eye movement. So I cannot do that caloric stimulation test and all. So it's not possible to declare because I'll not be able to prove certain sets of brainstem reflexes. So it's a little difficult. I mean, I'll tell you why Kaus is wrong. Kaus is basically wrong in this person because Riju is asking Kaus mnemonic. So I didn't tell Kaus because that is wrong. I'll come back to that. EEG may be flat or may not be flat. That doesn't matter because sometimes you can get some discernible waves in the EEG. Like for example, some delta waves are proven to happen even in the setting of a brain death. But EEG is not a very important criteria. So it's always clinical. Brain death is mostly clinical only. EEG is just a supplementary evidence. I'll come back to that. Then the patient should be able to go for apnea test. So ability to perform apnea test. Ability to perform apnea test in the sense throughout the apnea test, the patient should not be going for severe hypoxia, which means PaO2 should be at least more than 60, or at least saturation should be maintained at least more than 88% throughout the apnea test. So which means any time during the apnea test, if the patient goes for hypoxia, then I cannot be able to declare the patient is brain dead. So ability to go through the apnea test is also important. And finally, neuroimaging. The neuroimaging should be compatible with brainstem death. For example, you can prove that in the CT angiography, there is no flow to the brain, completely absent flow to the brain in a global vasospasm. So if you prove that kind of neuroimaging, then that also will be fine. And EEG is only a supplementary evidence for declaring a brain death. So let me talk about one by one. So what are the reflexes that are there so that I can prove? So you have multiple reflexes. For example, you start at the pontine level, then you go to the midbrain level, then you go to the medullary level, and you have the upper medullary level and the lower medullary level. From the midbrain level, you know the most important reflex is going to be the pupillar reflex. Pupillar reflex. And Indra is asking in brainstem death vitals can be stable because I think she's concerned with totally only questions. She has read a lot of questions, I think, all the while. And she's only concerned with the questions. So I think all these are questions basically in the previous year. That's why she's been asking the same thing from yesterday again and again. How can circulation continue once brainstem is gone? No, circulation in the sense we are talking about the carotid and the vertebral circulation. So if the brainstem is dead, what about the carotid circulation? I can't understand what your question is. That's one of the supplementary evidences we are talking about. Neuroimaging that is consistent with the brain death. And of course, brainstem death or brain death is completely beyond your current understanding, but I'm trying to simplify it. It's not as simple as that. It's a very complicated process and so many things are involved in that. Let me try to tell in a very simplified way. So one is the pupillary reflex. So pupillary reflex is going to basically be from the midbrain. There is nothing else that is involved in the pupillary reflex apart from the midbrain. All you need is the second cranial nerve and the Edinger-Westphal nucleus. That's all. If these and the third cranial nerve, if these are intact, so it's fine. So pupillary reflex, afferent is second nerve and efferent is the third cranial nerve, especially autonomic fibers from the Edinger-Westphal pathway. And you have, like certain reflexes like corneal reflex and conjunctival reflex. What is the seat of corneal reflex and conjunctival reflex? What is the afferent for corneal reflex? And what is the efferent for corneal reflex? Fifth nerve and seventh nerve. So corneal and conjunctival reflex is basically going to be from the pons, because both fifth nerve as well as seventh nerve. Fifth nerve is the afferent and the seventh nerve is the efferent. So both fifth and seventh nerve are present in the pons only. So corneal reflex and conjunctival reflex, I can tell it is coming from the pons. So if I prove absent corneal conjunctival reflex, to an extent I can tell that the patient is not having a functioning pons. Then how can you prove that the patient is having medullary dysfunction? For the upper medulla, I can prove 9th and 10th cranial nerve. So 9th and 10th cranial nerve in the sense like I can tell absent gag reflex. Gag reflex, cough reflex. If it is absent, then I can prove that the patient is probably having a absent 9th and 10th nerve, because these are basically mediated by predominantly by the 10th cranial nerve only, afferent and efferent. But 9th and 9th nerve is also partly involved. So whenever I tell gag and cough reflex is not there, so I can tell 9th and 10th cranial nerve are basically not there. like your cough reflex is easy to perform. Most of the patients will be intubated. Not most, all patients will be intubated. So you can put a, like a suction catheter into the endotracheal tube and go deep into the carina, and you can try stimulating the carina. So once you stimulate the carina, the patient should not be able to cough. And the patient should not be paralyzed as well. That's most important. So then I can prove that the gag and cough reflex will be completely absent. And the lower part of the medulla, I can prove because the vital centers are there. Respiratory centers, cardiac centers are there in the lower part of the medulla. The most important of them is the respiratory center. So lower centers, I'm going to tell that apnea is there. So which means my respiratory centers is not working, which means my lower part of the medulla is also not working. So that's what we refer to as something called an apnea test. Remember, we do apnea testing for 3 to 10 minutes, which means we'll disconnect the patient from the ventilator. And that should be there for a minimum of 3 to 10 minutes. That's very important. Minimum 3 minutes and up to 10 minutes we can do. When you have to stop is equivalent. So there should be some time where you should stop. So either you can stop when you reach that 5 minutes or 10 minutes, or you can stop when the PaCO2 reaches beyond 60 millimeters of mercury. Clear? Or increase in PaCO2. Increase in PaCO2 beyond 20 millimeters of mercury. 20 millimeters of mercury. So either absolute PaCO2 beyond 60 millimeters of mercury, or increase in PaCO2 by 20 millimeters of mercury from the baseline. Still, if the patient is not having any respiratory movement, then that's a sign of a complete apnea, and which means whenever CO2 is increasing, that should be able to stimulate your brainstem and the medulla to trigger breathing, because one of the important triggers for breathing is the CO2, carbon dioxide. So if the CO2 is increasing, but still it is not able to trigger the breathing, means the patient is having some problem in the respiratory center. So that's why we are proving that the lower part of the medulla is damaged if you prove that the patient is having apnea. Then there are other kind of reflexes also. For example, there are some reflexes that are typically originating from the pontomedullary junction. In a sense, like these are important for the pons as well as for the medulla. So what are the reflexes that are important in the pontomedullary junction? What are the reflexes that you do basically for pontomedullary junction? One important reflex that is called oculovestibular testing. What is that? Everyone would be aware of that, isn't it? What do you mean by oculovestibular testing? This is nothing but the caloric testing we are talking about. This is nothing but the caloric testing. And at the same time, we have something called a Dulce reflex also. I'm going to do two testing based on this. One is called as a caloric testing, and second one is called as a Dulce response, DR. So two things I'm going to check for. So basically, caloric testing also should be negative, and Dulce response also should be negative to declare the patient is a brain death. But we know all these things. Corneal conjunctival, everyone knows. Gog, cough reflex, everyone knows. Apnea, it's very easy to understand. But caloric testing and Dulce reflex is something that will be confused by everyone, even though how much ever times you study. So for that matters, we need to know why you have this response in the first place. And even before that, we need to know what are the types of eye movements are there to begin with. There are basically like three different types of eye movements. One is called saccadic eye movements. These are the most common eye movements that you ever see. So if I ask anyone who's listening to the class to look at one side slowly without performing saccades, it will not be possible. For example, if you want to look on the right side slowly without forming saccades, with a smooth movement, it will not be possible. You will be only making series of saccades so that you will be moving towards the right side. You will not be able to move, like in a very slow, continuous rhythmic fashion. That's a smooth pursuit. That is not possible at all if I don't do any maneuver. So everyone can try. If you want to move slowly towards the right side, it is impossible that you will move very slowly or steadily. You will only making a series of saccades like this. So that is a saccadic eye movement, which is a basic eye movement. Then second one, you have something called a smooth pursuit movement. Smooth pursuit is like opposite of saccades in the sense like you can make a slow eye movement. So this will happen only in one area when you follow a closely moving object. For example, if you see this pen or when you see this phone, because pen is not really visible. And if I tell like just follow this phone slowly as I move from left to right. So now in this setting, you'll be able to make a smooth pursuit movement, which means when you're following a closely moving object, then that will be fine. So you'll be making a smooth pursuit movement. So that will happen only when you are closely following a moving object. So then we have the final one, that is vestibulo-ocular reflex. So these are oculovestibular movements, or we call it as vestibulo-ocular reflex. So why we need this vestibulo-ocular reflex? I mean, you really need them. Why? Because whenever you move the eyes, there's a natural tendency, because eyeballs are basically located in the head only. There is something called inertia, and at the same time, whenever you suddenly move your heads, there is a lot of possibility that your eyeballs will move along with the head. So that's really, really important. So which means when I'm speaking, I'm turning my head, I'm seeing like this, I'm seeing like this. Still what I'm doing is, even though subconsciously what I'm doing is, I'm trying to focus on what you're typing, and I'm seeing what I'm writing, and I'm seeing you guys subconsciously. So how is this possible? Despite I'm turning my head to different locations, this is quite important, because when you fix a gaze on something, for example, so you're seeing a movie, or you're seeing something, some teacher is teaching something, you'll be turning your head in a lot of directions. You'll be turning like this, you'll be turning like this. So many positions you're turning your head. But still, once you fix your gaze is fixed on that particular object. Unless until you want to turn your gaze towards somewhere, you want to see something else, your gaze is fixed only there. Even despite turning the head, your eyes are fixed to a particular thing, unless until you wanted to change. So this is a very important thing. That is vestibulo-ocular reflex. Because what vestibulo-ocular reflex does is, when you turn the eye towards the right, when you turn your head towards the right, your eyeballs will turn towards the left. And whenever you turn the head towards the left, your eyeball will turn towards the right. So this is a subconscious response and an involuntary response, basically. And that's a very important response according to evolution, because otherwise, every time you turn your head, your eyeballs will fall along with the head, and you should need to voluntarily fix your gaze on something voluntarily every time, unnecessarily. So that's a very tough process. And or at least if you want to fix your eyeballs on one particular thing, it will be very difficult without vestibulo-ocular reflex. Otherwise, you want to hold your head like this so that you don't really turn your head on either side. So that's ridiculous, isn't it? So that is why, to avoid all those problems, you have vestibulo-ocular reflex, which corrects the movements for you. And that is also the basis of nystagmus. So whenever you rotate your head very fast, for example, you're sitting in a rolling chair and they rotate you extremely fast. So what really happens is, your head turns so fast that your eyeballs fall towards the direction of the head, but your vestibulo-ocular reflex will try to correct the eyeballs towards the other side. Yes, but what really happens is, the head is rotating so fast that the eyeballs will again move towards the side of the turning of the head. So the vestibulo-ocular reflex will slowly try to correct the eyeballs towards the other side. But since the rotation of the head here is more than, the speed of rotation of the head is more than what the vestibulo-ocular reflex can correct, so you will result in a setting of a nystagmus, where your eyeballs will move towards the direction of the rotation of the head, and vestibulo-ocular reflex will slowly correct to the opposite side. So as far as nystagmus is concerned, so usually you will have something called a two component. One is called a fast component, and second one is called a slow component. So usually your fast component will be towards the direction of the rotation of the head. Towards the direction of head rotation. So that will be the side of the fast component. And whenever you talk about the slow component, which means slow component is nothing but the vestibulo-ocular reflex that is trying to correct the rotation, so that it will be on the opposite side, opposite to the direction of rotation of head. Direction of rotation. So more importantly, one thing what you need to know is, this fast component is the one that is important, because the direction of nystagmus is usually denoted by the direction of the fast component. Direction of the nystagmus is basically denoted by the direction of the fast component only. So that's why this is an important point. So this kind of, rotation you cannot do, especially whenever a patient comes, you cannot ask them to rotate around the chair. So you can mimic a kind of rotation of the head through caloric stimulation. So whenever you give a warm water or a cold water, you know at what temperature going to be. Warm means 7 degrees above, that is 44 degrees Celsius. Cold means 7 degrees less, that is 30 degrees Celsius. So that is the cold water that we are talking about. So you'll be using a warm water and a cold water in this setting. So warm water will create a scenario like as if you are moving the head towards this one particular side, for example, same side. So warm water will create a scenario. For example, if you are injecting warm water into the right ear, it will create a scenario that is similar to, because of the stimulation of the semicircular canals. That needs a little bit of neuro-otology also, but I don't want to go into depth of that. But let us assume that warm water will create a scenario and it will mimic a scenario where the scenario is such like head is moving towards the right side. So cold water will create a scenario. Suppose if you are injecting a cold water into the right ear, it will create a scenario that is similar to movement of the head towards the left side. Head rotation. Clear? So as I told you, the fast component will always be towards the movement of the, movement of the rotation of the head, or movement towards the direction of the head rotation. So in this setting, you will get the fast component towards the right side only, and you will get the vestibulocular reflex, that is the slow component, towards the left side. And similarly, when you put a cold water, you will get the fast component towards the left side here, because you're injecting cold water into the right ear, and it will create a scenario like the head rotation is happening towards the left side. And of course, the fast component will be towards the direction of head rotation, and that's why you're producing a fast component towards the left. And you will have the slow component, that is the vestibulocular reflex, that is happening on the right side. So to avoid confusion, that's why your ENT textbooks will give a mnemonic called COWS, which means whenever you do a caloric stimulation in a normal individual, your nystagmus will be towards the right side if it's, same side if it's a warm water, and if it's in the opposite side if it's a cold water. So we are having something called a COWS mnemonic. So this is telling you the direction of nystagmus, which is the faster component. So cold means it will go to the opposite direction, warm means it will be in the same direction. But remember, vestibulocular reflex is something different. It's not like it will not be equal to that of the COWS mnemonic. Okay, fine. But more importantly, one small point that you need to understand is, in a comatose patient, this will not be possible. In a comatose patient, this fast component will not happen. Why? Because this fast component happens because of strong influence from the cortex. So without that cortical component, this fast component will not happen, which means that mimicking a simulation like that of a head rotation and all will happen only if the cortex is intact. In a comatose patient, if the cortex is not intact, you will not get the fast component, and you will be having only the slow component. So only the slow component will be there. That is, the vestibulocular reflex alone will be there if the patient is not having a cortical involvement. The cortex is not involved, so this is what you're going to get. So that is the reason, that is the basis of getting a Dulce reflex in a comatose patient. Suppose a patient who is comatose and having a severe and significant cortical involvement. So whenever you turn the head towards the right side. So now see, whenever you voluntarily turn the head towards the right side, because from the beginning we are talking only analogy on the right side. So that's why I'm telling right here. When you turn the head towards the right side, the vestibulocular reflex is going to turn the head towards the left side. Whenever you turn the head towards the left side, the vestibulocular reflex will move the eye towards the right side, which means here there is no cortical influence. And when there is no cortical influence on movement of the head, only your vestibulocular reflex will be there. That is going to move the eyes towards the opposite side. And this is what we refer to as Dulce response. And this can be checked only in comatose patients. In a conscious patient, Dulce response should not be checked. Because, for example, what is the reason for a conscious patient to do a Dulce? For example, if you have a eyeball like this, and I am seeing a particular staff nurse who is looking extremely beautiful for me. And when somebody turns me to the left side or the right side, doesn't matter, because the staff nurse is so hot, I'm going to look at her only. I'm not going to look at anywhere else. So because my cortical influence is strongly telling where to look. So only when you remove that cortical influence, you'll be getting only the vestibulocular reflex. And this is what we basically call as a Dulce response. That's really, really, really important to understand. So which means to produce a Dulce response, you need this brainstem, especially the pontomedullary junction. So that area is where your cranial nerves are concentrated, and that is the area from where your Dulce response is coming, which means the vestibulocular reflex is basically not a cortical response. It's basically a subcortical response. So even without the cortex, your vestibulocular reflex can be intact, which means if only the brainstem is intact, especially that pontomedullary junction is intact, you can produce a Dulce response. You can produce that vestibulocular reflex. Suppose if the brainstem is also damaged, then your caloric stimulation also will not yield any information, or Dulce response also will not yield any information, which means the patient eyes will be still and they'll not be able to move anything at all. No eye movement possible. And in caloric stimulation, and this is a very common question they ask. So, sir, okay, I understood the Dulce response, but suppose if the patient is having a coma, and if I do a caloric stimulation, what I will expect? Depending on cortex. Suppose let us assume the cortex is intact. The cortex is still there. I mean, patient is in coma because of some drowsiness or something. The cortex is intact, and if you're doing a caloric stimulation, in this setting, you will see the same Cow's response only. That's what you're going to expect. Because cortex is there, you can be able to produce fast component as well as a slow component, and the same Cow's is the response that you'll get. If you put cold water, the fast component will be towards the opposite side, and if you put a warm water, the fast component will be towards the same side. So that's fine. Suppose if the patient is having a decorticate rigidity, or if the patient is having a cortex issue, so the cortex is not intact, so there is some severe cortical problem. In this setting, you will not see the Cow's, you will be seeing the vestibulocular reflex alone. You will be seeing the vestibulocular reflex alone. So it's very simple to understand. For example, if you put a warm water in this setting, so it is like moving the head. For example, let us assume you are putting warm water into the right ear. If you are putting warm water into the right ear, because it's warm, it is like movement of head towards the right side. It mimics similar to right side head movement. I told you warm water mimics the rotation of the head towards the same side. So it's like right side head movement only. So if it's going to mimic a right sided head movement, so because here you don't have the cortical influence, only the vestibulocular reflex is there. If the purpose of vestibulocular reflex is if your head moves towards the right side, your eyeballs will move towards the left side. Similarly, if you are putting a cold water here, so it is like into the right ear, if you are putting a cold water, it is like mimicking a head movement towards the left side. It is mimicking a head movement towards the left side. If you are mimicking a head movement towards the left side, then of course, because here only vestibulocular reflex is there, your eyes will move towards the right side only. So which means here your entire rule of Cow's will be completely lost, which means when you are putting a warm water on the right ear, your eyes are moving towards the left side. Yes. And you are putting a cold water towards in the right ear, and your eyeballs are moving towards the right side. So many students confuse at this point only. They don't understand that there are two components in nystagmus, that is fast and slow, and the fast is due to cortex. The cortex is lost, you will get only vestibulocular reflex, and that's completely different. And the direction of nystagmus is basically in the direction of the fast component, and that's why the Cow's mnemonic is there. If you take the fast component out, and if you take the cortical influence, and you will not get this Cow's, and you will get something different only. And you have to clearly understand this. Remember, this Cow's mnemonic should be used only for nystagmus, not for vestibulocular reflex. Clear or not? Do you understand? Till this, are you understanding or not? I cannot explain a much easier way. This is the most easiest way I can explain this. Okay. So whenever you put a caloric stimulation in a brain dead patient, for example, let us assume the brainstem is also damaged. The patient is having a brainstem death. So in this scenario, you will not get any response. You will not get a Dulce reflex. You will not get a vestibulocular reflex, which means you will not get any caloric response also, which means the eyes will be still. Cortex is also dead. The brainstem is also dead, which means vestibulocular reflex also will not be there. Even that Dulce kind of a response also will not be there. So this is what happens in brainstem death, and that's what I'm trying to prove here. So that my caloric testing is negative and my Dulce response is also negative in this scenario. So I have to prove everything. So that, and the patient should never develop any nystagmus. Of course, this is, after telling all these things, this becomes very silly, isn't it? To tell that the patient should not develop any nystagmus. of course they won't develop. So if you're in cortical death itself, the patient will not get nystagmus. Suppose the brainstem death, how the patient will get nystagmus? Of course, the patient cannot get any nystagmus in the setting of a brainstem death. It's quite simple. That's all. Fine. I mean, in ENT, you'll be studying anyways. That is called oculokinetic nystagmus, and you have something called oculostatic nystagmus. Of course, oculokinetic nystagmus, you're good doing it in a chair, and oculostatic nystagmus, you will be doing it by seeing a drum. So that is something for an ENT kind of a sort of a thing. So I don't really want that for my particular discussion, because that's not really needed and nobody's going to ask that. And now finally oculokinetic, yes, drum. So you have drum and chair kind of a thing. So I don't really want that. Dolce is the same as oculocephalic reflex. Of course, yes. Same only, almost similar. Okay. So then finally, I need something to tell what are the things that are compatible with brain death and what are the things that are incompatible with brain death. So which means there are certain findings. If you find still they are compatible with brain death, which means you can still declare a brain death. And there are certain findings which are incompatible with brain death. For example, number one, the spinal reflexes may be intact. What are the spinal reflexes that you're seeing may still be intact in the setting of a brainstem death. So we are only declaring a brain and a brainstem death. We are not declaring a spinal cord death. So that's not a problem. So which means the deep tendon reflexes may be there. That do not exclude a brain death. So patients may have a Babinski positivity, which means many times in front of this is very important, because many times when I do a brainstem death examination, I always take the relatives with me, one of the close relative. While recording, they will be with me while performing, and I'll explain each and every step. And declaring a brain death gives you a lot of money as well. Sometimes you can charge up to 50,000 to 1 lakh also, declaring a brain death, depending on what kind of urgent scenario you are there. So it gives you a lot of money. At the same time, it is going to take a lot of pain, and future some legal issues may be there. So you have to take care of all these things. So that's why you have to be really careful. So you get the relative, and whenever you do a plantar response, if the patient moves their toes, definitely the relative will ask, like, what is that? The patient is moving. You tell the patient will not move anything. The patient is moving their toes. They don't know that it's a plantar Babinski response that's coming from the spinal cord. So you have to explain them beforehand itself. What are things that is expected and still can be brainstem death, and what are things that need not be expected to have a brainstem death. So in a Babinski, of course, it's coming from the spinal cord. So that can be there, and that does not rule out a brainstem death. And sometimes there can be spontaneous head turning. Head turning can be there. And again, that does not exclude a brainstem death, because that actually this is sort of reflex that comes from the spinal cord, cervical spinal cord level. So head turning can still be there. And there is something called a Lazarus sign. Lazarus sign. And it's again carried by the spinal cord only. For example, whenever the patient is given some painful stimulus, there will be a brief extension of the arms like this, and then they will fall on the chest. So this is what we refer to as Lazarus sign. There will be extension of the arms, and then they will fall on the chest. So this is Lazarus sign. And this is again a spinal cord reflex only, not mediated by any of the higher centers. So that does not exclude a brainstem death. And there is another sign called a thumbs up sign. So sometimes it's like a pseudo Babinski. In Babinski, your great toe is going to move. Similarly, your thumbs also can move to certain stimulus. So this is what we refer to as a thumbs up sign. So, and again, that does not exclude a brainstem death. Still, that's a spinal cord reflex, and that's fine. And maintaining vitals without support is absolutely possible. So don't think that the patients will be dead without any support. They can maintain the vitals without any sort of hemodynamic support like inotropes, or even though that will not be there for a long time, it's not possible, but transiently, for time being, for 2 days or 1 day or 6 hours, or it varies, of course. So they can maintain the vitals without any kind of hemodynamic support, and that does not exclude a brainstem death, because this T1 to L2 sympathetic outflow is there in the spinal cord only, which will be sometimes able to fire up and maintain the vital signs without any need of support. And certain kind of respiratory movements. I mean, this is again confusing. It's not apnea means we are talking about no breathing at all, but there are some respiratory movement is there, and that's a spinal cord reflex only, which means how can you tell whether it's a true respiratory movement or it's an apnea? So what I'm talking is about respiratory movements is possible, can be there, but you should demonstrate that this respiratory movement does not have any tidal volume. No tidal volume. These are just movements. They're not actually taking any sort of breath inside. A respiratory movement like thing can happen in betweenly. This is intermittently. This is not a continuous movement again. It will be very short movement and it will be a very intermittent. Very rarely you will see this kind of movement. But again in the ventilator, because patient will be in the ventilator if you see, ventilator will clearly show these movements will not take any tidal volume. No tidal volume will be there, zero. It's just a movement, kind of a movement that basically comes from the spinal cord again. So this is not a true respiration. This is still apnea only, but respiratory movement sort of a scenario can happen. All these are basically mediated from the spinal cord. So all these can be present in a patient. Still, it does not exclude brainstem death. So what are incompetent brainstem death? So number one, seizures. When the patient is having seizures, because seizures can happen only if there is a cortical activity. So simple. So without a cortical activity, you cannot get the seizure. So that completely rules out a brainstem death. That is incomplete the diagnosis of brainstem death. Second, any level of posturing. Any posturing, whatever may be the case, any level of posturing indicates goes against a brainstem death. So which means it could be a decorticate posturing or it could be a decerebrate posturing. So these are going to completely go against the diagnosis of a brainstem death. So it's not possible. So the next question automatically comes because we have introduced a new terminology called posturing. We need to know what is decerebrate and decorticate posturing. And that is based on the subcortical level influences. For example, in a brainstem, let us assume there are three areas. Again, the midbrain, the pons, and the medulla oblongata. So now you know you have a very important, midbrain tract. So that is basically coming from the red nucleus. Red nucleus is one of the important structures of the midbrain. You know that. The two ball-like structures in the middle of the midbrain. That's why the red nucleus will be there. And they're going to produce something called a rubrospinal tract. You know that. So basically I can tell this is a rubrospinal tract. And this is a very primitive tract. In animals, this is very important. But in humans, this is not important because this is suppressed by the pyramidal pathway. This is a very important extrapyramidal tract. Animals is very important, especially when they are walking in four legs. This rubrospinal tract becomes very important for them. So what is the main function of the rubrospinal tract? Basically, rubrospinal tract is an extrapyramidal tract. So they're basically trying to flex the limbs, especially the upper limb flexion is the most important aspect of a rubrospinal tract. Flexion of upper limbs. It can flex lower limbs to an extent, but flexion of upper limbs is the most important. And this rubrospinal tract is very advanced in animals, so that the trunk also will be flexed, so that they'll be walking in four legs. So as the evolution became better, this rubrospinal tract was actually inhibited by the corticospinal tract, the pyramidal tract. Slowly, the pyramidal tract gained a lot of advantage. And this pyramidal tract started inhibiting the rubrospinal tract. That's what they do. Basically, they inhibit the rubrospinal tract while coming down. So this is the corticospinal tract. Slowly, what happened is, because the rubrospinal tract's influence is gone, slowly initially the arms that are flexed, basically the arms that are flexed become a little extended. And because the trunk that is flexed also become a little extended, and slowly from evolution wise, if you see, as the corticospinal tract becomes strengthened, they become slowly upright. Monkeys, gorillas will be a little flexed, but humans become completely upright. So that is because of the complete domination of the corticospinal tract over a period of time in evolution. So that's rubrospinal tract for us, nevertheless. And we have many other pathways are there. Like for example, we have a tectospinal tract, we have a reticulospinal tract. So many other tracts are there that does something else. So let us see what they do. So let us assume we have something called a tectospinal tract. And let us assume we have, I'm drawing only approximately because these are diffuse tracts. They don't have any particular localization, but they originate from the brainstem only. So this is an example of a tectospinal tract. Let me talk about a reticulospinal tract. So these are also extrapyramidal pathways, and what these tectospinal and reticulospinal are doing. For example, you have tectospinal and you have reticulospinal. These are also extrapyramidal tracts which are strongly suppressed by the corticospinal tract. So what these are doing is, these are basically causing extension of upper limbs and lower limbs. And this is the basis of the decorticate and decerebrate rigidity. So, and remember, corticospinal tract tends to inhibit these kind of extrapyramidal tracts as well, which means corticospinal tract makes sure that the only dominant structure is corticospinal tract whenever you are conscious. That's all. So now, what is the base of decerebrate and decorticate rigidity? Suppose if you have a damage, suppose above the red nucleus, let us assume the damage is here. The damage is above the red nucleus, or usually in your textbook they'll give superior colliculus as the level, but superior colliculus and red nucleus are at almost the same level. So let us understand if it's above the midbrain, to be very easy to understand, above the midbrain or above the level of superior colliculus or above the level of red nucleus, whatever, everything is the same only. If there is above the level of midbrain, now there are two things that will happen. All these lower tracts will get released, number one. So one, rubberospinal tract will become active, and your other tectospinal and reticulospinal also will become active. Tectospinal and reticulospinal also will get active because the corticospinal tract influence is no longer there. So this rubberospinal tract, of course, we know it's one of the very powerful tracts. So they're going to produce upper limb flexion, and it's going to produce something called a lower limb extension. That's what is going to happen. So this combination of signs is what we refer to as something called a decorticate rigidity. I mean, which means you are removing the cortical influence. The corticospinal tract influence is lost. That's why it's called a decorticate rigidity, basically. Suppose if the damage is below the level of red nucleus or below the midbrain, but above the pons, below the midbrain, but above the pons, or in between ponto midbrain junction, or anything below the red nucleus or anything below the superior colliculus. If you have a damage, for just understanding purpose, I'm telling below the midbrain, but other tracts are intact means here the rubberospinal pathways is also damaged. So here there will be no rubberospinal pathways. There will be only tectospinal and reticulospinal pathways, which will be active, which will be resulting in uniform extension of upper limb and the lower limbs. And this kind of uniform upper limb and lower limb extension is what we refer to as something called a decerebrate pathway or a decerebrate posturing. Not decorticate, it's a decerebrate posturing. So which means whatever may be the posturing, doesn't matter. This posturing should be there only if some areas of the brainstem is still functioning. If brainstem is not functioning, posturing should not be there. So that is why any kind of posturing indicates intact brainstem, and it actually excludes brainstem death, and that's why these are incompatible with brainstem death. And that's a very important point as well. And at the same time, patient should not have any nystagmus. Even if they don't have eye movements, if they have, I mean, in the sense like if they have nystagmus, that excludes brainstem death again. So these are the findings that are incompatible with brainstem death, and you have some findings that are compatible with brainstem death also, which are very important as well. I think you can understand what I'm trying to tell, so that we can move on to the next. Clear? That's all. So now you know what happens in brainstem death. So what are the components of how to diagnose a brainstem death? I mean, why I told brainstem death is because that will help you in understanding the reflex also. Because I don't want to, because neurology is something, if you start from A to Z, if you go in an order, it's going to be really, really difficult for you. Like I have to tell the reflexes separately. I have to teach you the, pupillary pathway separately. So it's better whenever you study for competitive exams like this, it's better you learn now and then. So whenever you get a new thing, you read that time itself. Whenever you get some topic, you read that time itself. That's my way of teaching as far as the neurology is concerned, because I felt that will be more easier compared to starting from the beginning, like everything like anatomy to physiology to separately. If you go, it will be very difficult and it will be time consuming, and it will ultimately will not set the goal of what we wanted to learn in the first place. That's why it's better to go in this direction. It will be very useful for you as far as competitive exams is concerned. Then what about the differences? So we need to know something called a coma is there. And you need to differentiate this from something called a persistent vegetative state. We call PVS, persistent vegetative state. And then we have something called a locked-in state. Locked-in state. They will ask you the differences usually. So first of all, arousal. So, I mean, what will happen in the setting of coma? Arousal is impossible and eyes can never open in the setting of a coma. And as far as persistent vegetative state is concerned, Eyes can open here, even though patient cannot be aroused. Eyes can be opened. But remember, there will be no purposeful eye movement. I'll come back to that. Locked in state, eyes can be opened. Again, eyes can be opened here in locked in state. And remember, again, opening of the eyes is mediated through third cranial nerve. Opening of the eyes mediated through third cranial nerve. And because third cranial nerve is intact in a locked in state, midbrain is there. So your eyes can be open because that's done by levator palpebrae superior. So that's a very important difference. What about the awareness? Whether they'll be aware of the surroundings or not? No. As I told you, locked in state, the patient will be aware of the surroundings. They can feel the sufferings also, pain, temperature, everything they can feel. And what about the communication? Communication is impossible. Whatever you tell, the patient will do the same. But locked in state, the communication is possible. So how is it possible if they can't express? Very simple. There are some things which is still intact in patients with locked in state. Like for example, if you ask the patient to look up, because vertical gaze is still intact, it's not eye movement, vertical gaze itself is there in a locked in state. So you can ask the patient like this: if you understand what I am trying to tell, you open your eyes, they will open. And they will ask like, if you understand what I am telling, you can look up. The patient will try to look up. So which means there are certain things which are still intact locked in state, which you can actually use it for your communication. So communication will still possible in the setting of locked in state to some extent, but it's impossible in the other two states. And finally, the most important is the sleep wake cycle. This is the area that usually they'll be asking an exam. So sleep wake cycle will not be there, but will be intact in the other two. Remember, even persistent vegetative state, the sleep wake cycle will be intact. PVS is basically very easy to diagnose. When you go to ICU regularly, there will be a lot of patients who will be in the persistent vegetative state. I mean, time and again you will be seeing. For example, in persistent vegetative state, the patient, it's very difficult to convince the attenders that the patient is having a poor prognosis, because PVS itself is a poor prognosis. As far as the prognosis is concerned, coma and PVS is variable according to the cause. Depending on the cause, it can be variable. But locked in state is universally bad. There's no good prognosis. They will usually die within a period of 3-6 months, maybe. They don't survive beyond that. But persistent vegetative state and coma, depending on the cause of the coma and persistent vegetative state, the prognosis can be completely different. But nevertheless, in a persistent vegetative state, suppose if the patient is having a serious brain injury, or it's visible that the prognosis is bad, in that setting, it's very difficult to explain to the attenders, because many times what they will do is they will have a sleep wake cycle. Sometimes they can even smile also, but that will be completely irrelevant to what is happening in the surrounding. So that's it's an automatic brainstem activity or brain activity. So many times what happens is when the attender will come, usually they'll come to the ICU with kind of the religious sentiment. They will be taking the water from the church, or they'll be taking water from the mosque, or they will keep that kind of sendur and all. So they used to come with this kind of religious sentiment. So during that time, unfortunately, these patients with persistent vegetative state, sometimes when they keep that sendur or put that church water and all, sometimes what might happen is that's completely irrelevant. They will open their eyes and they will smile also. And once that happens, that's all. It's very difficult to convince the attenders, because they will believe that this thing works, and they will not accept that the prognosis is bad. They will think like we are lying. And that's why it's very important to tell that these kind of movements can happen in persistent vegetative state, that the opening the eyes, sudden kind of smile kind of, or suddenly they can cry also. Their emotions can surge out sometimes, but it will be completely purposeless. So what I will try to do is, if these kind of movements happen suddenly, and the attenders are coming and asking, sir, why these kind of movements are happening? Is the patient awake and alive? So what I will tell is, try the next time. Go and repeat the same thing. And if the patient does the same thing again, then I will agree to that. Then they will be there for 1 hour. They will try from the ears, eyes, nose, everywhere, but the patient will not respond. So they will come all of a sudden without any reason, without any trigger, and they will go off. And that is not purposeful. Whatever the movements they do, or whatever the smile they do, that is completely purposeless. And that will happen in a persistent vegetative state, which is quite expected. That can happen. But all these things will never happen in a coma. That's why usually in exam, the most important differentiating point is the fact that the sleep wake cycle. That's the thing that they will be asking most of the times in exam. So if you see the intact sleep wake cycle, usually in exam that goes towards a percent vegetative state. If you believe the patient is like a coma, but if they are given in the question that the sleep-wake cycle is intact, that goes towards a percent vegetative state only. Prognosis we cannot comment on right now. So that's a very important table as well. So many differences are there, but this is really important. And finally, we have something called a Parinot syndrome. This is the final syndrome that we need to know. Some questions are there in Parinot syndrome. This is also referred to as something called a dorsal midbrain syndrome. That's also referred to as something called a dorsal midbrain syndrome. As far as dorsal midbrain syndrome is there, the dorsal part of the midbrain, which is important for, you want point 2, GCS in persistent vegetative state. You're talking about, I mean, you're asking GCS is 2 or not. No, GCS will not be 2 here. GCS will be 3 only, I'll tell you. GCS will be 3 by 15 if you have not intubated. If you're not intubated, it will be 3 by 15 only. There won't be any this thing. You might thinking like it's a spontaneous eye opening, that is 4. But in a patient with persistent vegetative state, that spontaneous eye opening will not happen all the time. Will happen only when irrelevant, completely irrelevant to what's happening in the surrounding. That cannot be counted as a Glasgow Coma Scale. It will be 3 by 15 only, most of the times, the least GCS. So Parinot syndrome is dorsal midbrain syndrome. So as far as the dorsal midbrain syndrome is concerned, it's going to have some problem. The dorsal midbrain, we know that dorsal midbrain does a lot of things. Like for example, it does accommodation. It does something called vertical eye movement. So for all those things, dorsal midbrain is important. So usual cause of a dorsal midbrain syndrome or a Parinot syndrome will be pinealoma. I mean, this is a rare cause, but still pinealoma. Pineal gland is immediately behind, isn't it? So they can come and compress on the dorsal part of the midbrain. Or if it's the third ventricle dilatation due to some obstructive hydrocephalus, you can get impingement on the dorsal midbrain and dorsal midbrain syndrome and AV malformations, rarely multiple sclerosis. So remember in neurology, everywhere vascular cause will be there. Then one tumor cause will be there. One demyelination cause will be there. That is usually multiple sclerosis. So nothing is complete without this. For any disease, you can tell these 3 causes. Blindly, whenever you are attending a Viva OC, you will tell some vascular cause, some stroke-related cause, or some AV malformation-related cause. You can tell some tumoral cause, but if you tell a proper tumor, you should not tell like a random tumor. But if you tell tumor, they will agree. But if you tell some specific tumor, you will be caught. So if you are a final year in your answer Viva OC in neurology, if you want to tell the cause, remember vascular, tumor, demyelination will be there everywhere. Whatever may be the disease, in the central nervous system, these 3 things will be there everywhere. So there's no need to unnecessarily confuse in exam. If you tell these 3 things, universally everyone will agree because nobody can deny that these 3 can't produce something. So dorsal midbrain syndrome, almost the similar thing only. So, but what will be the clinical features? Clinical features, the most important thing will be vertical gaze palsy. That will be the most important. Vertical palsy. This is actually a supranuclear palsy, basically. So whenever you get a vertical gaze palsy isolated, that is called as a supranuclear palsy. And more importantly, what vertical gaze is affected is up gaze more than the down gaze. That's very important because there is another type of supranuclear palsy called as a progressive supranuclear palsy, which we'll be discussing in Parkinson disease. There you'll have a down gaze palsy involvement more than the up gaze palsy involvement. So here there will be up gaze palsy involved more than the down gaze palsy. Then, I mean, because the up gaze is involved more than the down gaze, the down pulling will be more compared to the upward pulling. So the eyes will be down always in them like that. That's called a sunset sign. That's called a sunset sign. This can happen in hydrocephalus itself. You would have studied in pediatrics, but that is due to the Parinot syndrome, dorsal midbrain compression. That is what we refer to as something called a sunset sign. And we have something called a Collier sign, C-O-L-L-I-E-R, Collier sign. The lid would be retracted, and that's due to a lot of reasons. No need to confuse here. That's called a Collier sign. The patients will have lid retraction, and finally, the patients will have a type of nystagmus called as a convergence retraction nystagmus. Convergence retraction nystagmus. So Parinot syndrome being a low yield area, but still 1 or 2 times they have asked previously. That's why I'm telling this. That's why I don't want to describe it completely. But nevertheless, you need to know vertical gaze palsy, where the patient's eyes will have more of up gaze palsy than down gaze palsy. The eyes will be down, called as a sunset sign. Then you have a Collier sign, lid retraction. Then you have a convergence retraction, nystagmus. Remember, these kind of vertical gaze palsies are basically supranuclear. Skew deviation in eyes is eyes moving to different directions. Like, I mean, it's one side one direction, other side another direction. That's a skew deviation of the eyes. It can also be seen in multiple brain stimulations, but that's very rare again. Okay, so with this we have completed as much as possible whatever we need to complete with regards to stroke, and most of the questions will be based on this only. Whatever I told you, that's where they're going to ask. They're not going to ask anything else apart from this. Clear? I think this must be it. Okay. I think now you know a lot of syndromes, isn't it? So don't get confused in exam. So many syndromes I have told. So we have started from lateral medullary syndrome, then Digerin-Rossi syndrome, then P1 syndrome, P2 syndrome. Then we discuss lateral pontine syndrome, medial medullary syndrome. Then we have Millard-Gubler syndrome, Foville syndrome. Then we have Raymond-Sestan syndrome, Weber syndrome, Claude syndrome, Northern-Nagel syndrome, pontine hemorrhage. We have Parinot syndrome, Locked-in syndrome, coma, persistent vegetative state, brainstem death. So all these things, how to differentiate, and all the pathways, whatever I've integrated here is going to be very important for exams. Hopefully you can answer these questions much better when you get the questions in the exam next time. So now finally we are moving on to the stroke treatment. Bulbar versus pseudobulbar. Okay. I mean, I didn't tell you basically. It's my fault only. I should have told bulbar palsy or pseudobulbar palsy that time itself. So what do you mean by bulbar palsy and what do you mean by pseudobulbar palsy? Remember, bulbar palsy, anything that produces LMN, lower cranial nerve paralysis, that is the bulbar palsy. Anything that produces LMN palsy of the lower cranial nerves. That's all. It can be unilateral or bilateral. Doesn't matter. So which means what I'm trying to tell is LMN can be affected either in unilateral disease or a bilateral disease. Both can produce problems in the lower motor neurons. As far as pseudobulbar palsy is concerned, you will have bilateral UMN, lower cranial nerve palsy. It should be UMN only and should be bilateral, because unilateral UMN involvement usually will not result in significant impairment. Only bilateral UMN involvement will result in significant impairment. I told you that is because of bilateral innervation of the nuclei by both the sides. And that one exception is the lower half of the face, which I have discussed yesterday itself. So what do you mean by this lower cranial nerves? Lower means typically I mean by 9, 10, 11, 12. But remember, it doesn't mean strictly, doesn't mean that only 9, 10, 11 or 12 must be involved. There can be some additions and there can be some subtraction. It's a vague term only. It's not like only 9, 10, 11, 12 or all 9, 10, 11, 12. There's nothing like that. So whenever the 9, 10, 11, 12 are damaged partly or in full, we call it as a bulbar palsy or a pseudobulbar palsy. And there can be an association with other cranial nerves also. For example, even 7th nerve can be damaged along with that. So it's not like it's only that 9, 10, 11, 12. There can be additions or there can be subtractions also. Doesn't matter. So it's a vague term. But nevertheless, it's a lower cranial nerve palsy. If it's bilateral UMN, we call it as a pseudobulbar. If it's a unilateral or bilateral LMN, we call it as a bulbar palsy. And more importantly, how to differentiate them is seeing the reflexes. The most important point is the jaw jerk. That's what they will ask. As far as the bulbar palsy is concerned, most of the times jaw jerk will be lost because you're having a LMN kind of a paralysis. But jaw jerk will be usually, they will tell brisk, but I don't know. I've never seen a brisk jaw jerk. It's usually whether it is present or absent. Normally itself, jaw jerk will be absent only. But if it's present itself, we'll take it as a brisk jaw jerk only. That's a sign of a pseudobulbar palsy. And what will be the gag reflex? Gag reflex will be still lost here. Gag reflex will be intact in the setting of a pseudobulbar palsy, of course. And what about emotions? Emotions variable, but generally lost, because most of the time 7th also will be impaired. If 7th is involved, then emotions will be completely lost. Patients will not have any sort of emotions if 7th is involved bilaterally. Whereas if the patient is having bilateral UMN type of paralysis, I mean complete loss of UMN, both the sides, the emotions will become hyperlabile. Emotions will be labile. I mean, you can remember like sort of a UMN versus LMN. So you will, I mean, right now you can later on, if there is time, I will discuss about the deep tendon reflexes later on. But now you can understand that your UMN, for example, corticospinal tract involvement, still you have deep tendon reflexes, isn't it? Like that, you can understand that gag reflex is also something similar to that. So in UMN lesions, you will have a gag reflex, and in LMN, you don't have a gag reflex. It will be lost. This time I'll explain you later on when I'm talking about the DTRs in the spinal cord. So emotions will be labile. Labile means they'll be crying, they'll be laughing, and there'll be a very labile emotion. So there'll not be a standard emotion. And then what will be the probable cause? Usual probable cause, the most important for exams is the Guillain-Barré syndrome. And you have multiple other causes also. But very importantly in exam, what they'll be expecting is this particular answer. That is a Guillain-Barré syndrome. Even lateral medullary syndrome also can cause this. For example, a Wallenberg syndrome can also cause a LMN 9, 10, 11, 12 palsy. I mean, except the 12, 9, 10, 11 palsy is possible. But whereas the pseudobulbar palsy is concerned, the most important cause is multiple sclerosis. If you're having a bilateral UMN, both the sides, there should be some diffuse disease in the brainstem. So usually it's a demyelinating disease, that's a multiple sclerosis. Apart from that, you can tell locked in state also. But locked in state is a generalized diagnosis. You cannot tell locked in state as a specific diagnosis because locked in state itself has multiple causes. Like I told you, osmotic demyelination syndrome due to faster correction of sodium. Multiple sclerosis itself can cause a locked in state. So locked in, you can tell, but that's not a specific cause. That's a diagnosis only. That's not a cause of the diagnosis. So these are two causes that you have to answer. And what about other features? The pseudobulbar patients will strongly exhibit something called a spastic dysarthria. Spastic type of dysarthria. And you would have seen this in many mental retarded children. When you go to MR homes and all, these children will be speaking like this. They will be looking like as if they are speaking with a lot of effort. They can still be able to speak, but they look like as if they are speaking with a lot of effort. Like they'll be speaking this is what we call. Like they will speak like this. That is because of the severe weakness of the muscles and their spastic muscles. So it look as if they are putting a lot of effort to speak, but that's how they speak. So that is what we typically call it as something called a spastic type of dysarthria. And it cannot be a aphasia, of course, because it's a subcortical lesion and it's not affecting the language centers. So it's not a aphasia. It's going to be a dysarthria only, spastic type of dysarthria. And what about the tongue involvement? So remember, as far as the tongue is concerned, it's a very common question in bulbar versus pseudobulbar. And because it's LMN, the tongue will be wasted and they will show fasciculations. Tongue will be wasted, very small tongue with a lot of fasciculations. Fasciculation is a sign of LMN. Of course, it's a sign of LMN. And you have then pseudobulbar palsy, it's a UMN. So tongue will be more spastic. They won't be wasted. And there won't be any fasciculations. Absent fasciculations, no fasciculations in the tongue. And it will be a spastic, it will be a small tongue, but still it will be very spastic. It will not be wasted or atrophied. Small spastic tongue, a completely atrophied and wasted tongue in bulbar palsy. So this is the difference between a pseudobulbar and a bulbar palsy basically. And these are old questions. I don't think bulbar or pseudobulbar difference they have asked that much in competitive exams in the recent times, in the last 3-4 years. Okay. Now with your consent, I can move to the stroke treatment. So what are the treatment of stroke? So how we are going to treat a stroke? So remember, first of all, whenever you suspect a stroke, this is a very simplified treatment. Suspect a stroke. So when you are going to suspect a stroke, whenever the patient is coming with an acute focal neurological deficit, that is always taken as a stroke unless proved otherwise. So now the next step is to see whether the symptoms of rapidly resolving or symptoms are not rapidly resolving. So symptoms not rapidly resolving or the signs not rapidly resolving. Let me write. The focal neurological deficit is not resolving, which means it's static or it is unresolved or it's worsening. Or it can be a rapidly resolving focal neurological deficit. So remember, if it's a rapidly resolving focal neurological deficit, then the diagnosis of stroke is unlikely. Then you have to think about something else, like probably it could be a migraine, or it could be even a transient ischemic attack. It could be hypoglycemia, something. So it's unlikely to be a stroke, but still can be a stroke, I'll tell you. I mean, your clinical examination will not rule out or cannot confirm. It can only tell whether it's likely or unlikely. So here, the stroke is very likely because it's static and it's an acute onset focal neurological deficit. It's very likely. So stroke unlikely means it could be a probable TIA. That's what you're thinking. Probable transient ischemic attack. So now in this setting, it's very important to tell whether it's what is the definition of a TIA. Remember, usually current definition of TIA is completely different, because everyone would have studied the older textbooks, and especially Indian author textbooks, where they will give TIAs diagnosed when the focal neurological deficit reverses completely within 24 hours. The focal neurological deficit does not reverse within 24 hours. They used to call it as a stroke. This kind of definitions have been given like 3-4 decades back, where the treatment of stroke is not advanced at all, and we did not use any form of intervention. So there, either whether it could be a TIA or whether it could be a stroke, the only treatment possible during those days is observation and conservative management. So that time, these kind of things are possible. Currently, waiting for 24 hours to confirm a TIA or a stroke is absolutely ridiculous. So any patient who's having a unresolved focal neurological deficit at the time of examination in the emergency is taken as a stroke unless proved otherwise. Any patient who has a completely resolved focal neurological deficit at the time of examination in the emergency is considered to be a TIA unless proved otherwise. So this is how currently we take. In the modern terminology, TIA should basically resolve within 10 minutes to 1 hour. Maximum usually takes. This is not a definition, but still it should resolve within a period of 10 minutes to 1 hour usually. Most of the times, this will be from the patient's history itself, which means the patient will tell, like, suddenly I got a complete weakness of my limb and I'm not able to speak at all. He will suddenly call the ambulance, or his attendants will call the ambulance. While coming in the ambulance itself, his movement will improve. And now after coming, he will tell, sir, I'm completely all right. I can move my limbs now. I can punch you also. Everything becomes all right. So they'll be very excited, because that's something, like very deadly, isn't it? Very scary. Suddenly you couldn't move the limb, and on the way it recovered. So in a way, the patient will have a sense of relief. So they'll be hyper excited. So sir, now I can move everything. So that's what they will do. So this is what is a classical presentation of a transient ischemic attack. So that's really important to understand. So stroke will not have any much recovery. Even if the patient comes to the ER, they will be lying down with a lot of focal neurological deficit that will be residual in the patient. So only in that setting, you should diagnose a TIA or a stroke. So don't use that definitions of 24 hours, which is completely unacceptable. Is night paralysis also a type of TIA shown in Conjuring and all? I don't know. Night paralysis, I have not seen. I don't remember. I've seen Conjuring all the both parts, and I think Annabelle also. Okay, Abhiram is telling happened to my grandma, and we are like, what's happening, sir? That's a TIA, very common entity, transient ischemic attack. But the problem with TIA is not like TIA is a completely reassuring sign, because it could be followed by a subsequent stroke. So because if one embolus is dislodged, another embolus can lock in that place and that can cause a stroke. So which means the patient has a risk of developing stroke subsequently. So that's why TIA is also dangerous basically. But nevertheless, at least it's not producing any deficit. Before that, we can treat something. So that's the idea. Suppose if the patient is having a TIA, likely if it's a TIA. Okay, just telling my senior had it at 3 p.m. after watching it. Okay. And he was very scared. Okay. So TIA. So now you know it's probable TIA. Now next step is to see the score called ABCD2 score. This is a score that we use basically for a TIA. So where A stands for age more than 60. Age more than 60, which carries 1 point. It's a very important score. Many times they have been asking this. BP more than or equal to 140/90. That is hypertension, which carries another 1 point. And you have C. C stands for clinical features. In the clinical features, if the patient is having only speech deficit, it carries 1 point. If the patient is having limb weakness or actual deviation of angle of mouth, in that setting, it carries 2 points basically in the clinical features. And D for the duration. Duration, if it is only for less than 10 minutes, it carries no points. If it is for 10 to 15 minutes, that means up to 1 hour, it carries 1 point. Anything beyond 1 hour, It carries 2 points. That's why it's called ABC2. And why it's D2? Because there is another D. This is the first D, and there is another D called diabetes mellitus, which carries another 1 point. So clear? So you can see the total score. It is 1, 2, 3, 4, 5, 6, 7. So total score is 7. So the score can range from 0 to 7. Clear? So depending on the ABCD2 score, suppose the ABCD2 score is less than or equal to 3, then in this setting, I'll be calling it as a low risk TAA. If the ABCD2 score is more than or equal to 4, then it's definitely a high risk TAA, even though there are a lot of exceptions. For example, there is something called a crescendo TAA. For example, patient is getting a TAA attack once completely resolved, and before coming to the hospital, or he didn't come to the hospital, within some 3-4 hours, he got another TAA, which produced even more severe FND. So this is called a crescendo type of TAA. Irrespective of the ABCD2 score, crescendo TAA always has a high risk only. So that even if the score is 2 and if he's having a crescendo TAA, that's a high risk for sure. So there are a lot of exceptions are there. So let us don't want to discuss about that. So anyways, if it's a low risk or a high risk, doesn't matter. You're going to do an MRI anyways. MRI definitely is mandatory, especially diffusion weighted sequences are very, very important. But you might be asking me, what the hell is this? If the patient is having a low risk or a high risk, you're going to an MRI. So why you want to categorize them in the first place? So this is a risk of development. I mean, why you have the ABCD score? Because this score is going to tell a risk of subsequent stroke, or the patient could have had a stroke already, but it's manifesting like a TAA. So that is why the ABCD score is there, to identify those high risk individuals who will develop a high chance of subsequent stroke, or who had already had a stroke, but just it is not manifesting because it's a very mild stroke. So that's why we have that ABCD score. So if it's a low risk, which means the patient is having a low risk of developing subsequent stroke in the next 24 to 48 hours, which means they can be managed as an outpatient basis. You can do MRI as an outpatient. You can ask them to come tomorrow and do an MRI. If the patient is having a high risk TAA, then in that setting, it's better to admit the patient and take a urgent MRI, which means inpatient means I'm going to take a urgent MRI within the next 24 hours. If it's an outpatient basis, means I can take MRI after 24 hours. No problem. After 24 hours, 24 hours, I can take the MRI as an outpatient basis here. So that's the idea. So it's urgent or a non-urgent MRI. Whether you want to take MRI immediately or you can take MRI later. That is the idea. And at the same time, this kind of ABCD score also tells you the risk of developing subsequent stroke. Remember, the highest risk of developing subsequent stroke after a TAA is in the period of next 24 to 48 hours. That's why even if you get a TAA, come to the hospital immediately. Don't be in home. Because within 24 to 48 hours, you can get a subsequent stroke. So that's highest risk of developing subsequent stroke is in the next 24 to 48 hours, even though the stroke can happen after 1 month or even after 1 year also. I'm not telling the maximum limit, but the highest chance of getting a subsequent stroke is in the next 24 to 48 hours. And if you do an MRI, if MRI does not show any infarct, or if the MRI shows an infarct. So if MRI does not show an infarct, this is where you diagnose a TAA. This is a modern definition of TAA again, where the MRI should not show an infarct. Then only you can diagnose a TAA. If MRI shows an infarct, it's not a TAA. First of all, understand it's definitely not a TAA. Even though if it's a completely reversed neurological deficit, it's not a TAA if MRI shows an infarct. So in that setting, you'll be diagnosing something like CITS, that is called a cerebral infarction with transient signs. That's what we call CITS, cerebral infarction with transient signs, or you can even call it as a non-disabling stroke. So, but it's a stroke, it's not a TAA if the MRI shows an infarct. But nevertheless, both will be managed in a similar way only. I'll tell you why. You might ask me why we are not doing thrombolysis. Because it's a non-disabling stroke, thrombolysis will not have any benefit. So I'll come back to that in some time. So this is what we refer to as a non-disabling stroke. So both will be managed in a similar way. Now, what I'm going to do is now I'm going to take both these patients and I'm going to take these patients to something called carotid Doppler or an MR angiogram of the neck or a CT angiogram of the neck, because I need to find out what is the luminal occlusion of the carotid vessels. So first thing I need to do is I have to rule out an atrial fibrillation and a LA clot. I mean, that could be the reason for the TAA. So AF and LA clot has to be ruled out. Ideally, I should do a transesophageal echo only. I mean, in a resource-rich setting, but in a resource-poor setting, at least minimum of a ECG and a transthoracic echo is mandatory in all these patients. That's the least minimum, ECG and a transthoracic echo. But in a resource-rich setting, you can go ahead with the transesophageal echo also, not a problem. Second, most important thing is like I need to do a carotid Doppler. Carotid Doppler. I'll see the intimal thickening and the stenosis of the carotid vessel. That could be the reason for the transient ischemic attack. And at the same time, alternatively, I can do something called the MR angiography of the neck. It is better compared to CT angiography of the neck because anyway, I'm going to do an MRI. At the same sitting, I can do the MR angiography of the neck also. So that is why MRI has a little bit of advantage. But the problem is MRI is going to take more time. At the same time, it's going to be more costly as well, MR angiography, compared to carotid artery Doppler. So nevertheless, why I'm doing carotid Doppler is to see the stenosis. See how much is the stenosis in the patient. So if the stenosis is going to be less than 50%, stenosis less than 50%, then in this setting, I'm going to give only medical management. I'm not going to use any interventional procedures. Like for example, I'll be using aspirin, statins. Of course, I need to use statins because it's a ASCVD and there is nothing that will stop you from using statins here. So statins has to be given and it should be a high intensity statins. It should not be a low intensity. It's a high intensity statin. I'll be using aspirin, statins and all this stuff. Or alternately, I can use clopidogrel also. If the stenosis is more than 50%, in this setting, you can try intervention if possible. And again, this is highly controversial. So depending on the percentage of stenosis, if it's 70 to 99%, then there is a definite benefit. You'll get a definite benefit out of it. You can definitely do some intervention, but 100% will not have any benefit because of full occlusion, again, you cannot do anything. Or if it is in the range of 50 to 69%, so in this setting, you have only doubtful benefit, and especially very elderly patients, very elderly with recurrent attacks of TIA, those are highly symptomatic during the attacks. So these patients may get benefit with a stenosis of 50 to 69% itself, but whenever it is more than 70%, it is definite benefit. Usually 100% or less than 50% usually will not get any benefit. 70 to 99 definite benefit, 50 to 69 doubtful. Certain group of patients will get some benefit because you're doing some intervention. And what are the intervention you can do? So there are two interventions. One is called a carotid endarterectomy. And second one, we have something called a carotid artery stenting of the carotid artery. Out of these two, what we generally prefer is the carotid endarterectomy only. That is the most commonly performed procedure and it's one of the preferred procedure also, because stenting has increased risk of stroke comparatively. The new stroke incidence is higher with stenting compared to that of carotid endarterectomy. So that is why the procedure that is followed in many areas basically. So fine. So this is how you are going to manage a transient ischemic attack or a non-disabling stroke. Now, if the FND is not resolving, come to the other side. The FND is not resolving, then it's likely to be a stroke only. So in this setting, the next step is going to be an urgent non-contrast CT. If you think it's a stroke, immediately you do an NCCT, non-contrast CT. When you do an urgent non-contrast CT, then endarterectomy is, you're going to trim off the stenosed area and they're going to rejoin. So that is endarterectomy. I mean, it's not basically a end-to-end anastomosis also. It's a different process where you trim the stenosed area. That is endarterectomy. So, okay, anyways, next is we are going to do a urgent NCCT, that is a non-contrast CT. In the non-contrast CT, the idea is to see whether the patient is having any focus of hemorrhage or not. The patient is having signs of hemorrhage, yes. The patient is having hemorrhage, then in this particular setting, you treat it like a hemorrhagic stroke. Which could be an ICH, ECH, or some form of stroke like SDH or EDH or subarachnoid hemorrhage. So something will be there. Versus a small possibility of venous stroke is also there. So keep that in mind. It's very rare, but a small possibility of venous stroke, especially as I told you, a beginner can confuse this small focus of hemorrhage as a hemorrhagic stroke. But easily it is, differentiatable, so it's not a big deal. So usually in this case, you are thinking about hemorrhagic stroke, so manage accordingly. Management accordingly to that of the hemorrhagic stroke, which you have discussed already. The patient is not having an hemorrhagic stroke. Now ask one question where the patient is having any evidence of acute severe headache, which is often forgotten. If the answer is yes, patient is having acute severe headache, then do a lumbar puncture. Because in this setting, whenever the patient is having acute severe headache, it's mandated to rule out a subarachnoid hemorrhage, aneurysmal rupture. So you should not forget that. So that's why if it is there, then go ahead with the lumbar puncture before going for the next step. So if the acute severe headache is not there, then probably in this setting, we can think about doing a thrombolysis. So if you want to do a thrombolysis, then you have to look at something called a LSW. That's called the last seen well time. So what do you mean by this last seen well time? So this is basically a window period kind of a thing. So here last seen well means when the patient's bystanders have seen the patient walking or at their usual self before last. That's very important because it can happen in the night. So we don't know when the stroke has happened. So it's not possible to tell the window period really, but you can tell when the patient is last seen well. The last seen well time is less than 4.5 hours or more than 4.5 hours. If it is within 4.5 hours, then you can think about doing a thrombolysis. So remember, if there are no contraindications, if no contraindications, you can go ahead with a thrombolysis in this setting. So usual drugs that we follow is alteplase. That's the usual standard drug that we give. Usual dose is, it should be kilogram based dose. So usual dose that we follow is 0.9 milligram per kilogram. In that 10% should be given as a bolus, and remaining 90% will be given as an infusion over 1 hour. The maximum dose that you should use in stroke is 90 milligram. If you take your pages back and see, in MI you would have used 100 milligram, but in stroke it's always a little less, 10 milligram less. 0.9 milligram per kilogram, maximum dose is 100 milligram. 90 milligram. In that 10% you will give as bolus and 90% you're going to give as an infusion over 1 hour. And you have tenecteplase also. Tenecteplase, the dose is 0.45 milligram per kilogram. As far as the MI is concerned, it's 0.5 milligram per kilogram. We're going to use a maximum dose of 45 milligram here. In MI, use 50 milligram maximum. Here, 45 milligram is the maximum. These are the two drugs that are useful for thrombolysis. Clear? If the patient is having, contraindication thrombolysis, or if the patient is having time period that has escalated beyond the window period, which means the patient is not within the window period, in that setting, you have to go for some alternative. So for that, there are two alternatives are there. One is conservative management and second is mechanical thrombectomy. So I will prefer where the patient is eligible for mechanical thrombectomy or not, beyond 4.5 hours. And this can be up to 24 hours. I'll tell you how. So whether you have to see whether the patient is mechanical thrombectomy eligible or not. If the patient is eligible for a mechanical thrombectomy, I'll tell you the criteria for eligibility. If yes, then you can go ahead with the mechanical thrombectomy. And if no, then it's better to go for a conservative management, conservative treatment. And remember, even if the patient is ineligible for thrombolysis, if lysis is contraindicated, of course, I can check the eligibility for mechanical thrombectomy. Similarly, even after thrombolysis, there's a vague idea, but even after lysis, post thrombolysis also, I can check the eligibility for mechanical thrombectomy. It is like, you can see, it will be similar to that of what you saw in the MI protocol. In MI, you saw after thrombolysis also, you did something called a pharmacoinvasive management, but it's not mandatory. Stroke guidelines are not very powerful compared to MI. So they will tell even after lysis, like how we do a pharmacoinvasive kind of a PCA there, you can even still try mechanical thrombectomy. If the lysis is contraindicated, of course, you're going to go for some intervention like mechanical thrombectomy. It's like a PCA here. If the patient is outside the window period, still you will be trying a PCA. So if you take this vaguely and apply in the MI guidelines, it will be almost similar, both of them. So they will match in a very decent way. So mechanical thrombectomy, you can imagine like a PCA here. Clear? First of all, you need to know what are the patients that are eligible for mechanical thrombectomy. Remember, there are certain eligibility criteria are there when I want to do a mechanical thrombectomy. That's what we're going to see. Remember, mechanical thrombectomy can be done currently up to 24 hours. Remember, it is best if done within 6 hours. That is the best time. But it can be done up to 24 hours. According to the current guideline, if there are some eligibility factors, it can be done up to 24 hours. Up to 1 day also you can do mechanical thrombectomy. Once again, if you see this 24-hour period cutoff, it will be similar to that of what you studied in MI. In MI also, I would have told like up to 24 hours you can do PCA. After 24 hours, the benefit is going to be extremely limited. You're not going to get that much of benefit, isn't it? Selected patients. So that's all. So to do a mechanical thrombectomy up to 24 hours. Remember, if it's done within 6 hours, then fine. You can take any patient for mechanical thrombectomy as far as the eligibility is okay. But when you can do up to 24 hours, is there any separate criteria or group of people where you can take up to 24 hours also? Yes, there is something called a Dawn eligibility criteria in mechanical thrombectomy. That's what I'm going to look for. So what do you mean by Dawn eligibility criteria is you're going to look for something called a infarct perfusion mismatch. So, or a clinical core mismatch. That's what we call an infarct perfusion mismatch. So for example, when you take a stroke, so let us take a normal stroke, and if you see the central area will be dead, completely dead. So this is what we call as an infarct. And if you take a vessel that is occluded, and the vessel would have had so many branches like this, and they'll have so many collateral circulation with other areas also. But nevertheless, whenever the vessel is occluded in an area, the one core area that is directly supplied by this vessel will be the first to get infarcted, and this area will be infarcted, and this will be a dead area. And of course, this area is not salvageable at all in the first place. But there is a surrounding area which can be still alive. It's like the same principle like that of a MI only, but brain will behave differently, that's all. The still surrounding area can be alive, but they will be having reduced function. In MI, how did you find out? In MI, you told like there are some areas which are having regional wall motion abnormality. Like that in brain, there will be no regional wall motion abnormality because brain is not like a moving structure. So they will have reduced function. This reduced function can be assessed clinically. Clinically, you can assess this reduced function, which means infarct of this whole area will perform clinically as a reduced function only, will manifest clinically as a reduced function only. But actually the infarct can be very small. So this area that is still alive, but it's not functioning properly, is what we refer to as ischemic penumbra. Ischemic penumbra. But clinically, it's very difficult to find out the ischemic penumbra because, infarct or the ischemic penumbra, both are going to manifest clinically as similar entity only. That is the focal neurological deficit. So it's very difficult to predict clinically what is the infarct and what is the ischemic penumbra. So that's why we need investigations for this. So we need two things now. We need an investigation that can pick out the infarct and that can pick out the perfusion, and we need a clinical examination. I need a clinical scoring system that can tell you the exact focal neurological deficit, so that we know all this data, so that we can exactly separate the infarct, ischemic penumbra, and the perfusion as well as the clinical disability, focal neurological deficit. Because if you all know all these things, we can tell how much is the size of the infarct, what is the perfusion to that area, whether it will be salvageable or not, what is the size of the ischemic penumbra, and at the same time, what is the total focal neurological deficit. So we need to know all these things. So to tell the infarct, so where is the infarct and where is the ischemic penumbra totally? So we have one important investigation called a diffusion weighted MRI, or we can do any sort of MRI. So we can do that. So to tell the perfusion to that particular area, we have something called a CT perfusion imaging. That's called a CTP. That's called a CT perfusion imaging can be done, so that we can tell. So based on these investigations, I can tell what is the size of the infarct basically, and the surrounding area is well perfused or less perfused. So based on that, I can clearly tell whether that area is salvageable or not. But still, I need to know the ischemic penumbra. To know the ischemic penumbra completely, my clinical examination is also important. I need to tell exactly what is the focal logical deficit, so that more the focal logical deficit and smaller the infarct means ischemic penumbra is huge. So more the focal logical deficit and more the bigger the infarct means ischemic penumbra is less. So that's how we call it as a clinical core mismatch. So what I need to find out is clinically, I'm having a large area of focal logical deficit, which means so much of focal logical deficit is there. But if I check for the infarct, it's very small sized infarct. And at the same time, perfusion is okay in that area. Only limited area is having loss of perfusion, but still that area, what I'm seeing, perfusion is okay. Then this is what we refer to as a clinical core mismatch. So whenever I prove that the patient is having a clinical core mismatch, I'm very sure that my ischemic penumbra is very big, has a huge ischemic penumbra, which is still salvageable. If this clinical core mismatch is not there, then I can assume that particular area is not salvageable. So that's why all these investigations are important. And that's the name came DAWN. DAWN means diffusion weighted imaging and CT perfusion imaging associated with clinical core mismatch in patients undergoing neurological intervention. So this is what we actually define as DAWN. That's the name that DAWN came. That's the DAWN eligibility criteria. So everything we know, now we know the CT perfusion, now we know the diffusion weighted MRI is going to tell you the size of the infarct and the perfusion status, but I still need to know what is the clinical FND. That will tell you a good idea about is there any clinical core mismatch. So for that, usually even before doing or even at the time of doing a non-contrast CT or even immediately after doing an NCCT itself, I'm going to assess one score called as NIHSS score. That is very important. This is a clinical score, NIHSS, that is going to tell what is my clinical severity. That is, what is my total FND status of the patient right now, focal logical status of the patient right now. That's called National Institute of Health Stroke Scale, even though currently it is not considered to be the gold standard, but it is the best as of now. We don't have any other option. So this is what we are using. That is National Institute of Health Stroke Scale. That's what we are going to use for assessing the stroke severity, basically, to start with. So remember, NIHSS should be used only for acute stroke severity. It's not used for assessing the stroke disability. So remember, stroke disability is different from stroke severity. Stroke disability means after the stroke, how much is the patient disabled? That's the residual sequelae of stroke. For that, we don't use NIHSS. NIHSS is used during acute stroke to assess the severity of the acute stroke. That's where NIHSS is used. Even NIHSS, you can categorize. So whether it's a mild stroke or a moderate stroke or a severe stroke, you can basically categorize based on the NIHSS score. So what is the category based on NIHSS score? For example, if the score is 0 to 1, I mean, the score ranges from 0 to 42 basically. The total score will be 0 to 42. It's completely clinical. You have 10 different points in exam. They won't ask you. But every single of my intern and resident in my hospital knows how to do this score. And they have a fixed case sheet like a pro forma. So at any patient who comes with an ischemic attack or a stroke or whatever it is, the first one resident will take the responsibility of filling the NIHSS scale, because this is a routine process in our hospital where they routinely do for every patient. If they don't do, they'll be fired really. It's very bad. So because based on this only, we are going to assess a lot of things subsequently. So 0 to 4 means we can call it as a minor stroke. Usually this is the place where your non-disabling strokes also will come, which means rapidly reversible symptoms, very less disability where it is not really appreciable by the patient. So this will be usually sometimes can manifest like a transient ischemic attack also, but you have to be careful. That's a stroke again. 0 to 4 is a minor stroke. 5 to 15 we call it as a mild stroke. Anything in the range of 15 to 20 we call it as a moderate stroke, and anything more than 21, that is 21 to 42, we can call it as a severe stroke. This is the classification according to NIHSS grading. Clear? 21 to 42. If the patient is having score of more than or equal to 25, there is a separate sub-entity is there that's called a very severe stroke. That's very severe stroke. That's separate entity is there. But anyways, nevertheless, the guidelines give only these 4: minor, mild, moderate, and severe stroke. That's completely based on clinical expertise. So I can tell one thing. Now I can tell the clinical core mismatch easily based on NIHSS score. Suppose if my NIHSS score is less than 10, NIHSS score is more than 10, plus my core infarct volume core volume means I'm talking about the core infarct volume. If my core infarct volume is more than 50 ml. So in that setting, I can tell. So my idea is very simple. I should have a low NHS score. At the same time, I should have a smaller infarct. So if my core volume is less than 31 ml, so in that setting, I can tell there is a core clinical mismatch. Or if my NHS score is more than 20, but my core infarct volume is very less than 51 ml. So once again, it's a very important criteria because based on this only, you can tell whether you can do mechanical thrombectomy still or still is there any salvageable areas there or not. What I'm trying to tell is my FND is big, but my infarct size is very small. FND is big, my infarct size is very small. So which means I'm proving there is something called a core clinical mismatch. So this clearly tells my dead area is very less, but clinically why I'm having a huge FND because ischemic penumbra. That is also showing up like a focal neurological deficit only. So which means there is a huge ischemic penumbra and still that can be salvageable. That is the idea where I can do mechanical thrombectomy even up to 24 hours. So best if it's done within 6 hours, but you can do up to 24 hours if you have certain eligibility criteria. Like there are many eligibility criteria that are coming up, but DAWN is the gold standard because it's the first criteria which showed that mechanical thrombectomy can be done up to 24 hours, not only up to 6 hours. Previously, before 2015, it's thought like it should be done within 6 hours, otherwise it's gone. But currently things are changing. Now they're telling thrombolysis can be done up to 6 hours in selected patients, not in all patients. I mean, you should not write all these things in exam. Now there is a new guideline that came. You can do thrombolysis up to 6 hours. And you can do mechanical thrombectomy up to 36 hours. That's a new guideline. But anyways, nevertheless, don't answer all these things. You tell window period for thrombolysis 4.5 hours and mechanical thrombectomy can be done up to 24 hours, provided if there is a proper selection criteria. So that's what we're going to see here. So what are the conservative management? Because conservative management is also very important in this setting because there are some few people who will not be going for all these interventions or thrombolysis. So we need to know the conservative management also. As far as the conservative management is concerned, first thing, you're going to start with some kind of antiplatelet agents. The most important here is aspirin. So all patients will receive aspirin. But is there any role for DAPT? You all know that there is DAPT means dual antiplatelet therapy. So you're going to ask a question that is there any role for dual antiplatelet therapy or double antiplatelet therapy in this setting? Answer is yes, there is a role of DAPT, but only for selected patients. For example, patients who are having a non-disabling stroke, which means it's a stroke, but there is no disability, residual disability, non-disabling stroke. Or second, if the patient is having a high risk TAA. High risk transient ischemic attack. Clear? So this is where you are going to use dual antiplatelet therapy. So how long you can give DAPT? DAPT is proven to be beneficial only if it is given up to 90 days, 3 months. Beyond that, beyond 90 days, no benefit again. Only bleeding risk will increase, but benefit is very poor. Beyond 90 days, you can, in these patients, you can use dual antiplatelet therapy up to 90 days. So which means after 90 days, what you will do? After 90 days, you are going to switch to aspirin monotherapy. But remember, in stroke, it's not like that. You can even use clopidogrel monotherapy also. Any one, if you prefer, it's enough. After 90 days, anyone is enough. Similarly, you can ask me one question, sir. Initially itself, can I start with clopidogrel? No, not like that. Initially, it's better to always start with aspirin because this is the only drug that has been proven to improve the mortality in ischemic stroke in the first 48 to 72 hours. So initially, you always start with aspirin. Later on, it's your decision. After 72 hours, it's your decision to give whether aspirin or clopidogrel. After that, no problem. Anyone you can try. Both are having equal efficacy according to a lot of modern trials. But initially, to start with, it's always recommended to start with aspirin alone. Don't start with clopidogrel. Or you start with the DAPT. If you encounter these kind of things, you can start with dual antiplatelet therapy, no problem. But most of the patients, to start with, if you are starting the monotherapy, start with aspirin only. Any specific dose of aspirin, that's quite controversial, but in stroke, we generally limit the dose to 181 to 165 milligrams per day. This is the dose that you should restrict. So you should not give a higher dose like 300 milligram or 325 milligram in stroke patients. 81 to 165 is the recommended dose, but generally we start with, in India, we start with 75 to 150 milligram because the dose of aspirin available in India is 75 or 150. So we start with 75 or 150 in stroke, depending on your personal expertise. And if you think bleeding risk is high, start at lower dose. If the bleeding risk is low, then start at a higher dose also. Even 150 milligram is fine. And now many neurologists are actually routinely recommending DAPT if the bleeding risk is low, even if the patient is having any kind of stroke. Please show the NHS and infarct volume part. What is the difficulty in that? NHS and infarct volume. It's quite simple, isn't it? Anyone has difficulty in understanding this clinical core mismatch? No, right? You can understand. You can understand, right? This clinical core mismatch, Dawn criteria, Dawn eligibility criteria. Yes, no problem. Okay. So, okay, aspirin. Yes, you start with aspirin. If you want to use a DAPT also, it's fine, but don't start with clopidogrel alone. That's the current idea. Clinical core mismatch is for doing up to 24 hours. Yes, this entire thing what we have discussed is to decide on why we are doing the mechanical thrombectomy up to 24 hours. But to do within 6 hours, it's not a problem at all. You have the routine eligibility criteria, that is different. So that need not be known. That's routine within 6 hours. Up to 24 hours, why you are doing? Because of that. Dawn eligibility criteria. And if you take one thing and look at it, it will be very confusing for you. The books will clearly tell that aspirin is the only drug that improves survival in the first 48 to 72 hours, which means in the first 2-3 days, the only drug that has been shown to be giving some sort of mortality benefit is aspirin only, which means in the first 48 to 72 hours, your thrombolysis is not giving any mortality benefit. Your mechanical thrombectomy is also giving any mortality benefit. That's, I mean, not much in the sense like very marginal mortality benefit is there, but that's not important. Only drug that provides a substantial mortality benefit and survival benefit in the first 48 to 72 hours is aspirin alone. Then there is a whole different question that comes into you, that pops up into your mind. Why should we do thrombolysis or mechanical thrombectomy? What is the need here? You can just leave it off, right? So you not do thrombolysis, you not do mechanical thrombectomy. What you want to do in the first place? The reason is because they provide a substantial disability benefit. Aspirin will not provide any disability benefit. It will provide only mortality benefit. But thrombolysis and mechanical thrombectomy can provide a substantial disability benefit. For example, the patient is having moderate disability after thrombolysis or mechanical thrombectomy. They can have mild disability or no disability. If the patient is having severe disability, I mean, the patient is going to end up with a severe disability. Patient may, after doing a thrombolysis or mechanical thrombectomy, patient may end up with a mild or moderate deficit, which means some disability improvement is still there. That's called a that's the advantage of doing a thrombolysis or mechanical thrombectomy. As far as mortality is concerned, lysis and mechanical thrombectomy are very, very poor in providing mortality benefit, but they give a good disability benefit, which means it makes the patient walk back again. Dawn criteria used for post-lysis MT also. No, for post-thrombolysis mechanical thrombectomy, we don't really use Dawn criteria. It's a routine thing. Immediately after thrombolysis, you are going to take for mechanical thrombectomy. After some 2 to 24 hours, you can take for mechanical thrombectomy. I don't think the Dawn criteria will be applicable there. So it's only for a primary mechanical thrombectomy, Dawn criteria will be applicable. So for patients, this Dawn criteria is particularly designed for patients who have missed the bus, which means patients who are presenting late. That is, the window period is more than 4.5 hours, but they have crossed that 6-hour mark also, which means beyond 6 hours, I told you the role of mechanical thrombectomy is highly questionable. So in those patients who have missed the bus initially and coming late, and at the same time, you want to do some intervention because the disability is a little severe. So in that setting, you can think about a Dawn eligibility criteria. So for primary MT, it's most useful. For post-lysis MT, it's not that useful. So for post-lysis MT, it's like a routine thing. Within 24 hours, you can take. Atorvastatin should be instituted to all patients. Again, that's what I'm trying to tell next. Statins, as far as statins are concerned, statins are going to be definitely beneficial, no doubt about that, but need not start immediately. You have to start immediately. To all patients need statins. There's no doubt about that. Any patient with a ischemic stroke or a what is that? TAA should be given high intensity statins. All patients. But when to institute is a question. Guidelines tell you can institute anytime within 24 hours. So it's not like you have to institute along with aspirin. Even though we give along with aspirin, it's not a must that you need to start statins along with aspirin. You can institute anytime in the first 24 hours. Even later also, not a big issue. Mechanical thrombectomy and aspirin can be combined. No, basically. So that's a good question. Usually, if you have done a thrombolysis or a mechanical thrombectomy, it is better to start aspirin after 24 hours. If you have done a thrombolysis or a mechanical thrombectomy, it's better to start aspirin after a period of 24 hours. You can wait for some time because of the risk of bleeding. If you have not started aspirin already, the patient is already taking aspirin and getting a stroke or a day, then that doesn't matter. If you're freshly starting aspirin, if you did a thrombolysis or a mechanical thrombectomy, it's better to start after 24 hours. I think you'll be getting that. Okay. In hemorrhagic stroke, after how many days aspirin is started? That's a controversial thing again. I believe that till the hemorrhage is completely resolved, and if you take a next CT, until the hemorrhage is completely resolved, you should not start aspirin minimum. That's the least minimum. But in the setting, if aspirin you believe is the cause of hemorrhage, I mean, usually it will not be the case. If you think it's the cause of hemorrhage, then it's better to withhold aspirin. And that's quite controversial. That based on personal clinical expertise only. There is no standard guideline to tell that particular point. It's all about your own decision. But I generally wait till the hemorrhage is completely resolved in CT. Till that, I won't restart. Any role of prophylactic antiepileptic? There is no role for prophylactic antiepileptic drugs unless until the patient throws a seizure. So that's very important again. So there's no role of prophylactic antiepileptic drug. Even though many neurologists do start with prophylactic antiepileptic drugs, I don't think there is any role. Maybe if the patient is going for a neurosurgery, I mean, the sense like because of severe edema, you want to take for neurosurgery, or if the patient is having significant cerebral edema, like we call it as a malignant cerebral edema, I'll tell you in some time. So in that setting, antiepileptic probably has a role. That too with a very poor evidence, but routinely it's not indicated. What topics after? What do you want? Because neurology is big. What topics you want after stroke? We can take whatever we want, not an issue. Okay, so we didn't come to that point where I told you lysis and mechanical thrombectomy are not going to be that, that beneficial when it comes to the mortality and survival. So they're going to only improve the disability. So that is why one of the important points to understand is if there is any pre-existing disability. For example, patient is already having a pre-existing disability. Pre-existing disability. This will not be effective. For example, lysis will not be effective, as mechanical thrombectomy will not be effective. Clear? Nilash is asking, clinical core mismatch is not there, then MT not done after 6 hours. Yes, of course, yes. Yes, that's what we've been talking till now. Okay. So, which means if there is a pre-existing disability in the patient already, there is something, or probably pre-existing stroke is there in the patient, which has caused a substantial disability, then if they're getting a recurrent stroke, then there is no point in doing a thrombolysis or mechanical thrombectomy, which means these investigation, these management options will only increase the risk of hemorrhage, and there is not going to provide any improvement. So this is a very important point as far as the entire stroke management is concerned. So how can you assess whether the patient is having pre-existing disability or not? There is something called a pre-stroke MRS. Pre-stroke MRS. This is very, very important. That's called a pre-stroke modified Rankin scale. So MRS stands for modified Rankin scale. So I told you for acute stroke severity, you have NHSS. Similarly, for post-stroke disability, after the stroke, how much is the residual disability in the patient is assessed by this Rankin scale. That's called modified Rankin scale or modified Rankin score. So as far as the modified Rankin scale is concerned, if the score is 0, then the patient has no disability. Don't write this because it's not that important. Then score is 1, the patient is having symptoms of disability, but actually there is no disability. Symptoms is there, that they are having some kind of neurological symptoms will be there, but disability will not be there if you examine them. To score 2 is patient will be having disability for sure, but the disability will be mild, and there are a lot of definitions within that to tell mild disability. 3 means you have moderate disability. 4 means you have a moderately severe disability. And 5 means very severe disability, and 6 means it's a dead patient, moribund. Score 1 means patient will have symptoms, like some neurological symptoms will be there. They will tell mild weakness, but if you examine the day-to-day life, there will be no disability. Symptoms there, but disability is not there. That is 1. 0 means no symptoms, no disability. 1 means symptoms, but no disability. 2, 3, 4, 5 are all will be having disability, depending on the how much disability is there. Depending on that, you can grade according to 2, 3, 4, or 5. 2 means mild disability, 3 means moderate, 4 means moderately severe, 5 means very severe disability, 6 means a dead patient. I mean, you can imagine this like probably, I think you would have studied in anesthesiology, isn't it? Some ASA grading is there before anesthesia. I think people who are in the final year or probably who attended anesthesia class must be knowing. So it's something similar to that, but don't equate that. Just for understanding, I told you. But overall, this is a disability score. So how much is the disability status of the patient at that point? So that's what is going to be found out by the MRS, that is modified Rankin scale. Suppose if the pre-stroke MRS is more than or equal to 2, the patient is having disability or patient is not having disability. The pre-stroke MRS, which means even before the current stroke, MRS is more than or equal to 2. I'm not telling mild. Disability there or disability is not there. That's the question. Pre-stroke MRS is more than or equal to 2, then the patient is having disability for sure. And which means if there is a pre-existing disability, already if the patient is disabled, that becomes a contraindication for thrombolysis and mechanical thrombectomy. You cannot do mechanical thrombectomy. I mean, more than thrombolysis, mechanical thrombectomy cannot be surely done in the presence of a pre-existing disability. But thrombolysis, currently it is approved. You can still do thrombolysis even if there is a pre-existing disability. But mechanical thrombectomy, definitely it's a contraindication. Any MRS, I mean pre-stroke MRS, more than or equal to, which means if there is a pre-existing disability, 100% mechanical thrombectomy cannot be done, which means the patient will become ineligible for mechanical thrombectomy. Even if all the other situation makes the patient eligible, if there is a pre-existing disability defined as pre-stroke MRS more than or equal to 2, they will be completely ineligible for mechanical thrombectomy. That's very important again. Okay. So fine. So these are some of the points I need to emphasize. Okay. Shubham wants spinal cord, cerebellum, and neuropathy. So which means you don't want anything inside the brain. After the stroke, you want to jump straight away to the spinal cord and to the peripheral nerves. Okay. So statins. So statins can be started anytime, not a problem. Then one thing that you need to know is DVT prophylaxis. So I need to start about that also, because BP we have discussed already, how to manage a BP. Fine. So I told already. So what is the importance of BP management? We have discussed in hypertension itself. But we did not discuss BP in the hemorrhagic stroke. In ischemic stroke, we know how to manage. We discussed already, where I told you if lysis eligible, then target BP should be less than 185/110 millimeters of mercury. If it's lysis eligible. Suppose the patient is lysis ineligible, the patient is not eligible for lysis, then the BP target should be less than 220/120. I think this is what we have studied some time back. Lysis eligible means the BP target is 185/110. Lysis ineligible means BP target is less than 120/120, 220/120. But in a hemorrhagic stroke, the BP targets are different, where the systolic blood pressure target is somewhere between 150 to 220. So this is the target, which means you don't really treat them if the BP is, unless the BP is more than 220. That's the idea. If the BP is more, if BP is more than 220, then only you will be treating that BP with antihypertensive drugs to reduce the BP. Otherwise, we will not treat unless until the BP is more than 220. So BP, we know that. So I don't want to discuss again. And target blood sugar less than 200, but avoid hypoglycemia. Hypoglycemia has a worst consequence, especially in ischemic stroke. So target glucose should be less than 200. Is there any role for therapeutic hypothermia? There is something called therapeutic hypothermia, which I have discussed for cardiac arrest. And this is having a very controversial role right now. Right now it is controversial because initial studies that did therapeutic hypothermia in a stroke patient told it's producing high mortality. Initial studies. But there has been some bias in those studies, so that's why studies have been reconducted now. So there are some studies which are doing therapeutic hypothermia in stroke. It's ongoing, so the results are not yet available. So once the results come, the situation might change. That currently, it's not advocated because it showed higher incidence of aspiration pneumonia and higher mortality. That's why we don't do it. Is there any role for anticoagulation in stroke? Which means I'm using heparin, warfarin. Any role for anticoagulation? Remember, there are very few indications for anticoagulation. Number one, the first topmost indication is a dissecting stroke. Any carotid or vertebral artery dissection causing stroke, I can use anticoagulation, but not in aortic dissection. Please be careful. And second, probably a venous stroke. Cortical venous thrombosis causing a stroke, I can use anticoagulation. Number three, third one is if the patient is having atrial fibrillation with a stroke. So I can use a prophylactic anticoagulation there. If the patient is having an AF and a stroke together, but you have to be a little careful even if the patient is having AF and a stroke. In this condition, if the stroke is massive, and there is no objective definition of a massive stroke, the stroke is too big and massive, and if the patient is having increased risk of bleeding, you can use the Hasbled score also for that. If the patient is having increased bleeding risk, avoid anticoagulation. You can wait, even in the presence of atrial fibrillation. If the stroke is small and the bleeding risk is less according to Hasbled score, then you can continue. You can give anticoagulation. But this is quite controversial whether to start or not, and depends on the size of the infarct at the same time, depending on the bleeding risk of the patient also. So if you have a very big infarct, high bleeding risk, that better to avoid the anticoagulation for a few days. Then you can restart later on. And here, why you are giving anticoagulation? The anticoagulation here you are giving for the purpose of atrial fibrillation, not for the purpose of ischemic stroke. Here you are giving anticoagulation because it's a venous thrombus, not for the purpose of stroke. Here you are giving because it's a dissection. That's the reason why you are giving anticoagulation, not for the purpose of ischemic stroke. Which means what I'm trying to say is in ischemic stroke, for ischemia per se, there is no role for anticoagulation. Anticoagulation has a very poor role and it's not going to be helpful in the first place. So these are the areas where you're going to give anticoagulation in a patient with a suspected stroke. And next one is DVT prophylaxis, which is mandatory for all stroke patients because one of the important cause of DVT is stroke. And DVT usually happens in the hemiparetic limb. We know that. So to avoid that, there are two options. One is called IPC, that is called intermittent pneumatic compression devices, very commonly used in ICUs. If you want to use intermittent pneumatic compression devices, give within 72 hours. It should be started within 72 hours. Beyond 72 hours, there is a good information and evidence that clot would have already formed, and giving IPCs after 72 hours is going to only increase the risk of embolism from the small deep vein clots also. So if you want to give IPC, you give within 72 hours. In cardioembolic stroke, how long to give anticoagulants? That depends on the AF. If the AF is stopped, then you stop the anticoagulation after that 3 weeks of cardioversion. So that's why I told you, in a cardioembolic stroke, you give anticoagulants for the purpose of AF, not for the purpose of stroke. So which means the guideline on how long to give anticoagulation in a cardioembolic stroke is going to be the same as that of atrial fibrillation guideline only. So IPCs, intermittent pneumatic compression, these are considered to be the best. There are two trials that have been done. One is called a CLOTS 1 and a CLOTS 2 trial. Both these trials demonstrated the superior efficacy of intermittent pneumatic compression devices. Then we have low molecular heparin, that is low dose prophylactic low molecular heparin. Usually the prophylactic dose is 0.4 ml, that is 40 milligram once a day dose is the prophylactic dose. That also you can give, but this is having a little higher risk of bleeding. That's why this is not preferred that much in the setting of a stroke. So which means if you want to start within 48 hours. It's best given within 48 hours. Beyond 48 hours, this prophylactic heparin doesn't have any role. But remember, the heparin we are talking about here in anticoagulation is a full dose therapeutic dose heparin. We're not talking about a prophylactic dose. The DVT prophylaxis, we are talking about a prophylactic dose of heparin. There are two different heparins we are talking about. Don't talk about that. less than 48 hours from last seen well time or less than 48 hours from the time of stroke? No, less than 48 hours from the time of our admission. So that is what we take. Don't confuse there. It's the hospital admission we are talking about. So once they come to hospital, this time on, everything is hospital admission only. Low moldaparin, even if hemorrhagic stroke. I clearly told you we are talking about an ischemic stroke. From here, I told you it's an ischemic stroke. From here onwards, we have completely removed the hemorrhagic stroke from our routine recommendation. And Vikram is asking now, you will give him low moldaparin even if it's a hemorrhagic stroke. First of all, is it logical? Are we going to give low moldaparin is hemorrhagic stroke? Point number one. So absolutely no. That's the answer. And we have left the hemorrhagic stroke long time back. And from this point onwards, we are only managing and dealing with an ischemic stroke. All the conservative management. So then why such a question in hemorrhagic stroke? Here, why I told in BP guidelines about hemorrhagic stroke is because I have not discussed that there. That's why I told you there. Otherwise, I not have told. So maybe if that is the thing that is confusing you. So then is DVT prophylaxis. So next problem that you're going to encounter is cerebral edema. Cerebral edema is the next problem that you're going to encounter. It's extremely common in a ischemic stroke, basically. In ischemic stroke, why cerebral edema happens? Because you are going to probably get a cytotoxic cerebral edema. So you know what's going to happen in a stroke. So if you take a neuron, so one thing that's going to happen is like the sodium potassium pump will get dysfunctional in the neuron. So of course, because of the low ATP and ischemia, you're going to result in low production of sodium, low working of the sodium potassium ATPase. Because of that, there's going to be too much sodium accumulation inside the cell. So this too much sodium accumulation is going to depolarize the cell, of course. This depolarization is dangerous because they're going to result in release of neurotransmitters. For example, excitatory neurotransmitters like glutamate. This glutamate is going to have more problem because it's going to create more issue because glutamate is going to act on glutamate receptors. You have NMDA receptors. You have many other receptors that are going to respond to glutamate. Most of the glutamate receptors are ion channels, basically. Are ion channels. They are going to further result in more sodium influx inside, because if you see NMDA, they're basically sodium channels only. So they're going to produce more influx of sodium, and this more influx of sodium will cause more depolarization and more glutamate release. And more glutamate release will produce more sodium influx. Remember, this sodium can bring in calcium easily, because once sodium is increased and depolarization wave is conducted, you're going to push in more calcium also. So this more calcium is the reason for more neurotransmitter release. And this more neurotransmitter release will result in more sodium and more calcium inside again. So this kind of vicious cycle will happen. And this form of like death of the neuron is what we refer to as glutamate excitotoxicity. But nevertheless, you can assume that sodium inside the cell is very high. If the sodium inside the cell is very high, they are going to result in more pulling of water as well. The water is pulled more into the cell, they'll go for an edema. So this form of edema due to excess water inside the cell, and that's because of excess sodium inside the cell, is what we refer to as a cytotoxic cerebral edema. Cytotoxic edema. And to remove this water, of course, and why the water is coming into the cell? Because of excess sodium, which means inside the cell you're having hyperosmolar state. That's why you're having excess water. To remove this water out of the cell, I need to use another agent that is producing hyperosmolarity in the blood. If I can create an hyperosmolarity in the extracellular fluid, then I can pull this water out of the cell so that I can reduce the edema. So these hyperosmolar substances are nothing but 3% NaCl. These hyperosmolar substances are nothing but 3% NaCl, and I can use something called a mannitol. There are two substances which I can use, which means I'm going to use another hyperosmolar agent that is going to pull this water out of the neuron. And these are nothing but 3% NaCl and mannitol. That's why whenever in your life you talk about a cytotoxic cerebral edema, you're going to use a hyperosmolar agent like 3% NaCl or mannitol. So that is why in cerebral edema, especially for stroke purposes, because it is due to accumulation of water and it's causing a cytotoxic edema, you're going to use 3% NaCl or mannitol. These are going to be the best drugs for any cytotoxic edema for that matters. So this is a real-time problem. So you need to know when the cerebral edema is going to peak, basically. Usually the cerebral edema is going to start by around second day to start with. It's going to peak by day 3 to 5. So this is the time they peak. They have a peak cerebral edema. And by day 6, it starts resolving. Resolution from day 6. But usually resolution will be complete by around day 14. By day 14, the resolution will be complete. And after that, the brain will actually shrink because of liquefaction necrosis. So this edema and increased intracranial pressure is going to happen usually during this day 3 to 5, where it's going to peak. But it starts at around day 2 itself. So this is the, evolution of the cerebral edema. First of all, to avoid the cerebral edema, what you will do, that's the question. And second, can you understand the cerebral edema before itself and you can do something? That's the second question. Or the cerebral edema comes and how we are going to treat it. That's the third question. So first of all, to prevent the cerebral edema is impossible. You cannot prevent the cerebral edema. Anyway, it's going to come. So there's nothing that can prevent. If there is an infarct, there will be cerebral edema for sure. But you can try to prevent the death due to the cerebral edema, because if it's a massive stroke, definitely the amount of edema you're going to get is very high and it's going to be a big edema, and that's going to substantially increase the intracranial pressure. So once you have a raised ICP, there is a risk of herniation and even death. So one of the important reasons for severe disability after a stroke and one of the important reasons for death after a stroke is cerebral edema. And this is something serious and you have to really manage it. So for that, to do whether a prophylactic craniotomy or not, you have something called a state criteria. So state is an acronym for a particular criteria which tells you whether you can do a prophylactic craniotomy or not. So what do you mean by state? S stands for the score. Score means we're talking about a GCS. If it's less than 8, that's one of the important indications. And T stands for time. So especially if you do within 48 hours, the procedures are going to be absolutely beneficial. If you're doing after 48 hours, you can still do. I'm not telling you should not do, but the benefit is better and best if you do within 48 hours. And A stands for age. If the age is less than 60, the benefit is very good compared to old age patients. T stands for time, territory. Time we already discussed. T stands for territory. Territory means we're talking about MCA territory because MCA is the most important. That's the one that's going to produce a huge edema. If the stroke is present in the MCA territory, especially if it's involving more than 50% of the MCA territory or more than half of the MCA territory, or if the volume of the infarct is more than 145 ml. The volume of infarct is more than 145 ml by your routine diffusion-weighted MRI and other studies, then this kind of infarcts will be called as malignant MCA infarcts. Malignant MCA territory infarcts, which means for sure they will get a cerebral edema. And in fact, it will be clinically problematic and they're going to produce a huge cerebral edema so that the patient can die of cerebral edema. That's why these are called as malignant. So what is the definition of malignant MCA infarct? More than 50% of the MCA territory or volume more than 145 ml is the definition of a malignant MCA territory infarct. Next, life expectancy. If the life expectancy is high, which means the patient is expected to live for a longer time, not like a frail cancer patient or old age patient. So the young patient with a high life expectancy. These are the patients who are going to get the best benefit from your surgeries. That too, if you do very, very early. Clear? If you do very early, it's going to be very, very beneficial. So what you can do is see whether the patient is within 48 hours or not. First of all, a patient with ischemic stroke is developing a cerebral edema or about to develop a cerebral edema. If the patient has not got a cerebral edema, see whether state criteria is applicable or not. State eligible. Then in those patients, you can do a prophylactic craniotomy. Prophylactic craniotomy also. The patient is state criteria eligible, then in that setting, you can directly go for prophylactic craniotomy. What do you mean by prophylactic craniotomy? You take a piece of skull, you put a series of burr holes, you take a piece of skull and implant in the abdomen with a good vascular graft. So put it in the abdomen. And of course, these patients are going to definitely develop cerebral edema. During the time of development of cerebral edema, the brain will expand. And now, because, if you have not done the craniotomy, the brain has to compress itself and they'll produce herniation and all. Now you have given a good space for the brain to expand, so the brain will come out It'll expand, release its pressure into the atmosphere. Later on, it's going to shrink. So the patient will not die. That's the idea. Or if the patient is state ineligible, the patient is not eligible for state criteria, which means that impact is small in such a case, you can observe the patient carefully without doing any prophylactic craniectomy. Or if the patient has already developed cerebral edema, already developed a substantial cerebral edema in this setting, you observe with mannitol or 3% NaCl. That's the next step. Suppose this mannitol and 3% NaCl is not responding properly, then in that setting you can take for a therapeutic craniectomy. So here there is a high risk of herniation again, because patient is not responding to mannitol and 3% NaCl, then you can take for a therapeutic craniectomy in this setting. So, but generally it's more of a clinical decision, even though giving it as a guideline kind of a stuff. There are few patients we anticipate and take even without cerebral edema. There are few patients, even if they develop cerebral edema, we wait for some time. It's all about a clinical decision, but still this will tell you a good idea about when to take for a prophylactic craniectomy. Remember, the patient is state eligible, huge in fact, young patients, and you want to save them, do a prophylactic craniectomy. Very good procedure. And they will survive most of the time. How to check responsiveness of mannitol and cerebral edema? There are two areas where you can assess cerebral edema. Cerebral edema can be assessed by two ways. One way to assess cerebral edema is the Glasgow Coma Scale, GCS. Remember, falling GCS from the baseline GCS is one of the very, very important signs of a cerebral edema, or a raised ICP for that matters. Because cerebral edema, we believe it as a raised ICP. That's what we wanted actually. So one of the first signs of raised ICP is falling GCS. GCS declines from the previous value. The patient is getting more drowsy. Patient is slowly moving into a comatose state. That's very likely to be a raised ICP in a post ischemic stroke patient. And second, CT brain. Of course, very important. Neurosurgery department, I told you, will not work without CT brain in the first place. So CT brain is really, really important. Where in CT brain, you're going to look for edema. What is the size? What is the progression? What is the value compared to the previous number? All these things you can see in the CT. Plain CT itself can show all these things. You do not need a contrast. Second, you can see the mass effect of this edema. You can see the midline shift. You can see the compression of the ventricles. Remember, what do you mean by mass effect? So whenever there is a midline shift. So for example, you see for midline shift, you see the septum pellucidum. I told you, if it shifted substantially to the other side. And at the same time, there will be compression of the ipsilateral ventricles. So that's a very important sign. If you remember, I've showed you that image. Wherever there is mass effect, on that particular side where there is a mass lesion, there will be compression of the ventricles. On the other side, ventricle will be big. On the side of space occupying lesion, the ventricle will be flattened and they will be very small because of the mass effect. So compressed ventricles, midline shift, these are evidences of mass effect. So whenever there is a declining GCS, always you confirm with the CT. If the CT shows significant edema and mass effect, then of course I'm going to take for a therapeutic craniectomy. If the patient is not responding. If the patient is having a good GCS after giving mannitol and 3% NaCl, maintaining normally, then I will continue with the mannitol and 3% NaCl only. If the GCS is low, if the GCS is decreasing, then I'll do a CT. If the CT is showing substantial edema and mass effect, immediately I'll push the patient to theatre to do a therapeutic craniectomy. Or even if without the cerebral edema, if the patient is state eligible, which means they're likely to develop a significant cerebral edema in the form of malignant MCI territory infarct is there, it's better to do a prophylactic craniectomy in these fellows. There are other options for cerebral edema. As I told you, if they ask you as a treatment treatment of cerebral edema as a whole. So number one, standard raised ICP management. So first is head end elevation by at least 30 degree. You keep it 30 degree. That is the standard head end elevation. And second is mannitol or 3% NaCl. And third, if the patient is intubated, I can do hyperventilation with the target PaCO2 of approximately 30 to 35, but better target is around 35. Lowering too much is also going to produce ischemia, because as the CO2 lowers, there will be vasoconstriction in the brain. So ischemia will happen. So around 30 to 35 will be better, but 35 will be much better. So maintain at that range. Give a little bit of hyperventilation to the patient. And number 4, if nothing works, I'm going to take for craniectomy. Release the pressure. That's all. That's a surgery. So these are the options that are available for cerebral edema. Remember, these are the options that are available for any raised ICP patients, including a traumatic brain injury. This is what I'm going to do. And at the same time, there are other surrogate other options are there which you can use for raised ICP patients. Like for example, you can do sedation paralysis, because if the patient is moving their limbs, then that will create a sort of kind of a stress to the body, and raised ICP will still happen. So do a good sedation paralysis, which means you need a good intubation also. So intubate, sedate, paralyze, and do a little bit of hyperventilation through intubation, and give mannitol, head and elevation. All these things will definitely work. So if it doesn't work, then as a final choice, you're going to take for craniectomy these patients. So these are the usual treatment options that is available for cerebral edema, or in fact for that any patient with a raised ICP. This is the general treatment option that we are going to give. Clear? And of course, you have other extravagant options like CSF removal and all. Steroid can be used in cerebral edema. No, it depends again on what type of cerebral edema, because we have talked about only one type of cerebral edema, that is cytotoxic cerebral edema. But you have another type of cerebral edema called vasogenic cerebral edema. You have vasogenic edema, that's another type of cerebral edema. In vasogenic cerebral edema, you have to use dexamethasone, that is steroids only. Because vasogenic cerebral edema usually happens in the setting of a space occupying lesion. So whenever there is a space occupying lesion, this is not a water kind of a stuff. This is space occupying lesion that they're going to compress the vessels. Compress the vessels, they're going to produce this kind of vascular compression. Because the vascular compression that the space occupying lesion is causing, you are going to get an edema. You'll be getting an edema. And that is why if you see in a space occupying lesion, you'll be seeing edema surrounding the space occupying lesion. Whereas in a stroke, diffusely you will see cerebral edema. I think those who have been in the wards will be noting this very clearly. So space occupying lesion will be having cerebral edema surrounding it. Edema surrounding the space occupying lesion. Whereas in a stroke patient, there will be a diffuse, like full area, wherever the stroke is there, you will have edema diffusely. So that itself will tell you whether it's a vasogenic or a cytotoxic edema. For cytotoxic edema, these are the best. For vasogenic edema, of course, dexamethasone is the best, where they can reduce the edema dramatically. So this is the common consensus, but there is a lot of misuse of steroids also. For example, for cytotoxic edema, giving a steroid has absolutely no role, according to me. There is no role for dexamethasone. Similarly, for a vasogenic edema, giving a mannitol or a 3% ACL, I don't think there is any role, but still some neurologists do use 3% ACL or mannitol even for a vasogenic edema. But I believe that dexamethasone is going to be the most important treatment for a vasogenic edema. Any role? I already asked. Prophylactic antiepileptics, controversial. So let me tell you, if you still want to know other options in a raised ICP, I mean, this is not for routine cerebral edema. Raised ICP, you can do a CSF removal. CSF removal is also advocated, but remember, this is best done in traumatic brain injury only. This is not done in all the cases of raised ICP. For traumatic brain injury, CSF removal is advocated, but suddenly, immediately, if I tell CSF removal, students will ask, sir, in raised ICP, if I put a lumbar puncture, the brain will herniate and the patient will go for herniation and they will die. We have studied that lumbar puncture is contraindicated in patients with raised ICP. Yes, absolutely true. In a raised ICP, definitely lumbar puncture is absolutely contraindicated. I'm not telling no. But the CSF removal, what I'm going to do here is through EVD. There is something called an external ventricular drain. You should not do lumbar puncture. Instead, we'll do something called an external ventricular drain. Through that only, I'm going to do CSF removal. I'm not going to do CSF removal through the lumbar puncture. Remember, it's a raised intracranial pressure. So usually, any object moves from a region of higher pressure to a region of lower pressure. So in a raised ICP, if you do a lumbar puncture, of course, you are creating a low pressure in the spinal cord by compressing to the outside. So suddenly the brain, which is having high pressure, tend to come down, herniate down into the spinal cord. So that is absolutely contraindicated. So what I'm trying to do is, I'm doing external ventricular drain. I'm using a needle and a catheter to break open the skull. I'll use a drill. So put a drill and break open the skull, and I enter the ventricles, and I'm using a EVD, external ventricular drain. Clear? I'm using a drain to directly like decompress the ventricles. So if I'm decompressing in the skull, then that won't be an issue because the skull pressure is the one I'm decompressing to the outside. So that's like a sort of a craniectomy only. So that's not a problem. But lumbar puncture is definitely contraindicated, so you should not do. So EVD is fine. Advantage of EVD in a traumatic brain injury, external ventricular drain has two advantages. One, you can do CSF removal and you can somehow reduce the pressure within the cranial cavity. And at the same time, you can see the intracranial pressure. What is the actual intracranial pressure? Exact ICP can be measured. So that's one option. So why you have EVD there, external ventricular drain. So it has double advantage for monitoring also at the same time for removal of CSF as well. So that's point number one. And anti-epileptics are very controversial, even though quality of evidence is very poor. If the patient is having a low GCS, and if you don't have continuous EEG monitoring in your setup, if the patient is having low GCS and expanding edema, you can give prophylactic antiepileptics, but low quality evidence. That has to be stated. The low quality evidence, but still you can give antiepileptics if the patient is having a declining GCS and you don't have a continuous EEG monitoring, and if the edema is also expanding and the ICP is increasing or in external ventricular drain catheter, so you can give antiepileptics, not a problem. But once the seizure comes, there is no doubt. So you're going to start with antiepileptics for sure. But prophylaxis, low quality evidence, but still you can start if you want prophylactic antiepileptics, but it's a low quality evidence. These are about the conservative management of stroke. And I'll send you for a lunch break after the contraindications for thrombolysis. So what are the contraindications for thrombolysis? Contraindication. What are the contraindications? You are going to type, so which you have discussed already. What are the contraindications for stroke thrombolysis? Recent MI, that's a relative contraindication. That's not an absolute contraindication. So we are going to finish off this complete topic with contraindication thrombolysis. You have absolute contraindication and you have relative contraindication. Number one is age less than 18. Consent is very important. Considered to be absolute contraindication. TPA use within 1 year. No, that is not a contraindication. Second, if the patient is having a massive stroke. I'm telling stroke specific. First of all, let us finish off the stroke specific. Massive stroke. Massive stroke in the sense like if the patient is having MCA territory involvement, I mean more than 1/3 of the MCA territory is involved. So if there is more than 1/3 of the MCA territory is involved, so that's basically a massive stroke. I mean, yes, I mean, leave the contraindications I told already in the, where? Your cardiology in the MI. So leave that. That's not a problem here. We are seeing the stroke specific contraindications. So massive stroke. Then if the patient is having rapidly resolving symptoms, that's a very important point, because if the patient is having rapidly resolving symptoms, then there are two ways you can think about. One is thrombolysis provides a disability benefit. If the symptoms are themselves rapidly resolving, then what additional benefit you will get with thrombolysis? Second, if the patient is having a rapidly resolving symptom, then it could be a TIA. So for whose purpose you are thrombolysing? So if it's a TIA, you are thrombolysing a patient who is not having an infarct in the first place. So again, rapidly resolving symptoms is going to be a contraindication. Then if the patient is having hypo or hyperglycemia. For stroke thrombolysis, this becomes important because hypoglycemia is supposed to be a great mimicker in neurology, which can mimic stroke, migraine, can mimic anything in neurology. So any hypo or severe hyperglycemia, like if the blood glucose values are less than 50 or more than 400, you should wait until the glucose becomes a little normal. So and prove that the symptoms that you're seeing is not basically due to hypo or hyperglycemia, then it's better to start with thrombolysis. So this is one thing. And there is another relative contraindication. These are absolute basically contraindications. There are some relative contraindications for stroke thrombolysis. Like for example, pre-existing disability. Remember, for mechanical thrombectomy, this is an ineligibility criteria. You cannot do. But for stroke thrombolysis, it is relative contraindication only. Pre-existing disability. It's a relative contraindication. Apart from that, one more absolute contraindication is there. One more absolute contraindication is there. Coagulopathy. Coagulopathy is an absolute contraindication. Actually, ACCHA defines this coagulopathy also. Like if prothrombin time more than 15 seconds, or APTT more than 40 seconds, or if INR is more than 1.7, or any bleeding risk, like platelet less than 1 lakh. So if this is there, then again it becomes an absolute contraindication. Then if the patient, other things we know already, if the patient is having aortic dissection, you don't thrombolyze. So everything is going to be the same. So relative is the pre-existing disability. So, and one more relative contraindication is a recent myocardial infarction. Recent myocardial infarction. So that's a relative contraindication. So apart from that, everything is going to be the same. So whatever is studied for myocardial infarction, it's going to be the same. There's no difference. Apart from this, that's all. So BP is a relative contraindication again. There you have studied no BP, but here there will be a little change in the BP. There we studied 180, 110. Here we'll study 185, 110. That's all. Why massive stroke? Because significant risk of bleeding is there. Stroke thrombolysis is not like the same as that of what you think for MI thrombolysis. If it's a massive stroke, very big stroke, then two reasons. One, the probability of getting a disability with that kind of a massive stroke is definitely already there, and thrombolysis is going to only show you more risk than benefit. At the same time, massive strokes always have a risk of bleeding, even if you start with aspirin. And there is a risk of something called hemorrhagic transformation of an ischemic stroke. Usually that happens in a massive stroke. The more bigger the stroke is, higher is the risk of bleeding. The smaller the stroke is, lesser is the risk of bleeding. Aneurysm, of course, it's going to be an absolute contraindication, especially if it's more than 1 centimeter. Any untreated aneurysm. I think the contraindication for that I've given in the MI itself. In MI, I think in absolute contraindication, I told any aneurysm, untreated space occupying lesion, or untreated AV malformation in the brain, especially aneurysm more than 1 centimeter, is an absolute contraindication. If you go back and see the MI contraindications, the lysis contraindication in MI, I would have given everything there itself. So you can apply the same, plus you can use these contraindications also. So only the additional points I've told you here, because it's not good to write again everything. Why recent MI? Recent MI, the most important reason is patient would have already been taking anticoagulants, because definitely the patient would have been in DAPT, that is dual antiplatelet therapy. As far the rationale is concerned, they would have been taking clopidogrel and aspirin together. So once again, there is going to be a higher risk of bleeding if you give a thrombolysis in this scenario. So that is probably one reason. Do you understand? Clear or not? Yes. So fine. So we have understood, like that's all. So from morning, we have discussed a lot of interesting stuff, isn't it? So stroke treatment is very important. Remember, whatever I told you in the stroke treatment, conservative treatment, everything is a question. Whatever I told you, all these things have been asked in exams. So be very clear, because this BP is a very important thing. Multiple times asked questions. So don't forget that BP. And one more thing is fever. Fever is a very bad sign in stroke. Patient should never get a fever, and it should be rapidly treated. See, remember, fever has a very, very poor prognostic value in the setting of, for example, post-cardiac arrest. In post-ROC state, fever is extremely bad. Similarly, in a stroke also, fever is extremely bad. So then next question they'll be asking you is in therapeutic hypothermia. In therapeutic hypothermia, where are the areas where you can use therapeutic hypothermia? Definite benefit for therapeutic hypothermia you will get in post-cardiac arrest, in the post-ROC state, where multiple trials have proven the benefit. So there is unquestionable benefit there. Borderline benefit, okay, you can do in the setting of a traumatic brain injury. If the TBI, traumatic brain injury, is causing raised ICP, then fine. So it's having some benefit, even though some trials are telling no benefit, some trials are telling good benefit, but still it's no harm. You can still try. But in ischemic stroke, right now, it's been proven that it's going to increase mortality. So as of now, current data, post-ROC, definitely yes. TBI, okay. Ischemic stroke, definitely no. So this is the current data as far as therapeutic hypothermia is concerned. Fever, dangerous in any entity. So even in stroke or even cardiac arrest, doesn't matter. Fever is something that is very ominous and it has to be treated very rapidly. So that's asking, after correcting hyperglycemia, can we consider thrombolysis? Yes, of course, you can consider thrombolysis. If the patient is in within window period, then that's fine. More than hypo is very important. See, hyper, rare to cause FNDs and all, but hypos can cause focal deficits. So hypos can mimic stroke. So hypo to correct it hardly takes, like how long? 10 minutes or 15 minutes is going to take. You're going to put 25D, the hypos will be corrected. So that's very easy. So yes, after giving a hypo or hyper, we can, if you're thinking it's a stroke, you can do thrombolysis. And finally, one point I need to tell is, we have done a NCCT here, non-contrast CT. Once you have done a urgent non-contrast CT, I told you if there is no hemorrhage and if there is no acute severe headache, at this point itself, I am thinking it's a ischemic stroke only. Even though it is not mentioned here, it is understandable. So if the patient is not having any hemorrhage evidence in the CT and if the patient is not having any evidence of acute severe headache in the history, straightforward, this acute FND, I'll be taking at an ischemic stroke unless put otherwise, which means it's clear that the role of non-contrast CT is to rule out hemorrhage. The role of non-contrast CT is not to diagnose an ischemic stroke. So the role of non-contrast CT is not to diagnose an ischemic stroke. The role of non-contrast CT is basically to rule out an hemorrhage. So, but NCCT itself can be very valuable. There are some signs which you can see in the non-contrast CT. So the first sign that is very popular is the dense MCA sign. That's called a dense middle cerebral artery sign. I think no radiology teacher will complete the neurology session without showing this dense MCA. So there's no point in me showing that dense middle cerebral artery sign. It's nothing that the thrombus in the middle cerebral artery. If you take the yesterday's image, because we're using the same page basically, so I can go for the yesterday's image. If you take this image, in yesterday's image, you see the proximal MCA occlusion, isn't it? This is the MCA, what I'm drawing right now. So let us take, this is the MCA over here. If you take this area, there can be a occlusion with the thrombus, and this area can be clearly seen. This thrombus that is present within the MCA can be clearly seen in the CT as hyperdense structure in that area. That's what we refer to as a dense MCA sign. So that's a very important sign, and that has a high specificity. Even though sensitivity is very poor, you'll not be able to see that sign very commonly, but specificity of the sign is very high. If you see that sign in a patient with a stroke, definitely that is classical of a ischemic stroke. Number one, that's called a dense MCA sign. Second sign that you can look for is something called a loss of gray-white differentiation. Loss of gray-white differentiation. And this is very, very important in a region called insula. That's also referred to as something called the insular ribbon sign. You know what is insula, isn't it? If to understand insula, you have the Sylvian fissure here, lateral fissure. When you, above the Sylvian fissure, you have frontal lobe, and below the Sylvian fissure, you have the temporal lobe. So what you can do is you can, in the Sylvian fissure, you can insinuate the fingers and drag the lobes up and down like this. Inside, you will see some more cortex that is continuing along with the frontal lobe and becoming the parietal lobe. Temporal lobe. That is that area of communication inside that goes like a ridge and comes out. So that is what we call it as an insula, and that's an insular ribbon sign. Basically speaking, in a CT brain, I'll show you maybe after the break. In a CT brain, the gray matter will look differently, white matter will look differently. To small extent, they will be different. For example, white matter in a CT, for example, if you take this is the white matter, that will be immediately below the cortex. That will look a little dark basically, even though it is called a white matter. Basically, a gray matter will look white in a CT. That's how it look white. Even though you call it as gray matter, it looks a little white in the CT, and if you tell white matter, that will look a little dark. So which means there will be a small distinction between the gray and the white matter as far as the CT is concerned, and that is very prominent in the insular ribbon area. So near the insula, because within the insula, you will have the basal ganglia structures and you will have the internal capsule moving on. So this is the commonest area that is affected by stroke because that is supplied by the MCA territory. in many MC-territory strokes, that's a very common area that will be affected. So this area will be involved in stroke very commonly. So whenever there is a stroke that is happening in that area, this gray-white differentiation will be lost. In the sense, so you will not be able to see this particular gray-white kind of a differentiation. Instead, you will be able to see only as a dark hypodense area. Everything will look dark, and this loss of gray-white differentiation is what we refer to as, yes, this loss of gray-white differentiation is what we refer to as insular ribbon sign if it happens at the insular area. And this is a very sensitive, I mean, it's a very specific sign basically. Sometimes you will miss it, but in different windows of the CT, it's very easy to pick up. It's not a big deal at all. But in the routine CT film, if you see, you will not be able to pick up this. If you have to go to the radiology room, and if you go into the radiology room, there you will have this, you can alter the Hounsfield units, you can change the windows and see. If you change the windows and see, it will be very easy to look this gray-white differentiation, I mean loss of gray-white differentiation and all, but in the films it's very difficult to appreciate because, like, you know why? Because films are having a fixed attenuation, so it's very difficult to see in a film. Go to the radiology room and appreciate these signs. That's a loss of gray-white differentiation, insular ribbon sign. So in exam, if they are supposed to ask, they will be asking you these two signs only. One is a dense MCA sign, and second is a insular ribbon sign. Do you understand? Clear. So remember these signs. I think now it's time for your lunch. I mean, I tend to call it as after my class, I tend to usually call it as something called a hard-earned lunch, isn't it? That's what we call. Okay, fine. So yeah, hard-earned by parents. Okay. Okay, bye-bye. See you. See you in the next session. Bye. I think time you'll ask then. So time will be like, yeah, next question that. So 3:45 to 4, somewhere around that time. So have a good lunch and come back.